Bore da I chi gyd, a croeso i Bwrdd Iechyd Prifysgol Aneurin Bevan. Good morning, everybody, and welcome to the meeting of the Aneurin Bevan Health Board. Can I just start with two wonderful announcements? Firstly, congratulations to Nicola, who was successfully appointed, absolutely smashed the field, yesterday to be our Chief Executive, and many, many congratulations. We're very, very pleased. Thank you. Panel that consisted of a number of chairs and of course the Director General were particularly pleased that it was somebody who'd been brought up in the Welsh health system that was successful. And that really has got to spur us on, it's one of her first jobs, to ensure that we do effectively identify all the talent that is within our services and ensure that they're given the opportunities to progress and develop so that we can make sure that we have the best in Wales. And that they will be successful and will be supported effectively. So she's a little glowing example for Welsh training and development. And of course, her own individual characteristics and competencies really did shine through. And thank you very much.
Thank you. Thank you. And it's really a privilege and pleasure. We look forward to it. And
even after the last 2 weeks.
You know, tested me to the end.
Yeah,
I felt like at one point that it was all staged just to test whether I would actually survive.
Yes,
unfortunately it was real, but you know.
Yes, it was. Yeah, it was real and it was very, very difficult. But you successfully managed the very tricky circumstances. My second great pleasure is to welcome Carol Walton, who's our infant feeding advisor. And I shall shuffle myself over the 7 legs to see you now. Carol doesn't look it, but she's worked within the NHS for, I know, for 60 years. You can't believe it, really, can you? Somebody looked that well. And we're all standing around here for about 900. She was brilliant. She was trained at St Thomas's, very famous hospital, and one that certainly I know, even in my time, everybody hurtled down to London to be trained in St Thomas's because that was the place to go. So she trained in St Thomas's. And then did your midwifery training in Scotland, and you seem to move all over the country, but always return to Scotland before finally coming to Wales. And I can remember you were a radiotherapy nurse in Western General. I remember doing a review in Western General. Oh, it's there all the way. So in Western General Hospital in Edinburgh, as a staff midwife in Preston, I also did a review in Preston too, so I know those well. And then back to St Thomas's before returning to Scotland as a midwife and then coming to us, thank goodness. She has, well, I don't know how anybody works for 60 years for the health service, I have to say. It shows absolute determination and great loyalty. But our patients and those in Scotland and wherever else you have worked have really, really benefited from your expertise. You're our infant feeding advisor and have the MBE for your services to women and children, which is brilliant. So I should like to, on behalf of the board, present you with your plaque. I've never presented anybody with a plaque for 60 years service before. Your plaque and your flowers. They're quite unusual, aren't they? Little card. But you advised me that you brought some slight mementos with you. Well, I have to say it's not. Go on, you tell them what you brought. A frilly cap. Do you remember frilly caps? Anybody remember frilly caps? I do.
I only brought a couple of things because I thought nobody would believe me. And in fact, I did get phoned up by my head of midwifery who said, could I prove that I'd actually worked with long to do do a lot of rummaging, and I just brought a couple of things just in case you didn't believe me. So one of which is my frilly cap, actually.
Shall I hold
Which
that one?
is, yes, that's lovely. Which is actually very limp because I didn't starch it.
Oh, it's standards are dropping here.
But there is a really simple photograph, but it does prove that I did actually wear it. Don't grimace.
You have to put these on the pulse page.
No, I don't think that's. So, and I'll just show you the date just to prove that I started. That's when I said I did. But there, at the beginning, it says my name and the date, 30th of June, 1962.
God, yeah.
So that's the day I started.
Wonderful. And you've got your medal.
I haven't got my MBE.
Oh, naughty girl.
Well, I was expecting to.
Yeah. Yes, great.
So my Nightingale badge is the
Is it?
same as that, but that's my Nightingale badge.
Lovely.
And I'm a trustee of the Nightingale Fellowship, actually. So it's quite a special.
Yeah, but it is. Thank you ever so much. And thank you for bringing all your, so James will make sure that we capture the moment and put it on the website.
With my very limited Welsh. Diolch yn fawr. Well, thank you so much. This is such an honour.
Thank you. Thank you. Any glasses? Thank you so much.
No, no. Just-
Thank you so much. Thank you.
Thank you very much.
Bye.
Well, I've got.
Okay. Thank you. I simply cannot believe anybody's worked for 6 years. I think it's remarkable, quite frankly. Anyway, it's nice to be able to start the meeting so positively. I really enjoyed that. The apologies for absence. Ewan is floating around the Mediterranean, but I think everybody else is here.
Yeah.
Yeah, thank you. Any declarations of interest for noting on the items on the agenda? Yes, Richard.
Chair 37A, I was one of the naughty people that opposed the closure, so I declare an interest on
Okay, thank you very much. That will note that. Thank you, Richard. The minutes of the Health Board meeting held on the 25th of May and the 14th of June for approval. Are there any amendments that anybody wishes to make? No? So I can adopt these? Yes? You happy? Okay. The board action log.
Thanks, Chair. So there's 5 actions included within the log, all with updates provided in the progress column. I wasn't going to go through those in detail, but I would ask respective leads to answer any questions arising from the updates provided.
Thank you. Okay. Are there any queries on this action log? Could I just mention, which I think vaguely fits with ABUHB 2505/16, and particularly the report from WISC. We have today received in the public domain a paper from the Welsh Ambulance Service Trust the general meeting, which is to be held, I think, tomorrow, on actions to mitigate real-time avoidable patient harm in the context of extreme and sustained pressure across urgent and emergency care. I will circulate this to the board members, but it provides an overview on behalf of the Welsh Ambulance Service Trust of the issues that they will need to put into place with the service, with us, and with their own service to mitigate the pressures that we are all feeling at the moment. There will be a board briefing session on the 10th of August, where we've already agreed that we will be discussing urgent and emergency care and West services. So I expect this to form a fundamental part of that discussion. If that is okay, if you're happy that I handle it like that, but it would be helpful if you read it in the context of the work that we're doing on urgent and emergency care and the alleviation of pressures. So thank you very much for that. The report on sealed documents. Ronnie.
Thanks, Chair. So this paper provides a summary of the use of Chair's action and the Board Common Seal during the period between the 10th of May and the 11th of July. There have been 7 documents that required sealing during this period, and they're set out in the paper. And there have been 2 Chair's actions agreed during that period. And again, detail is provided in the report. And so the board is asked to ratify the use of the Common Seal and the use of Chair's action in line with standing orders, please.
Are you content with that recommendation? Thank you. The Chair's report, I'm afraid it's a bit long, but then I don't know, this last 2 months have been incredibly busy. Apart from my usual meetings and discussions on a bilateral with you, I've had numerous discussions with the Chief Executive, Carol Shillerbeer-Powys, who is the lead on the problems being experienced by the health service and by social care relating to delayed discharges of care and the development of a plan to create 1,000 bed equivalents, but an additional 1,000 bed equivalents by October 22. The Health Board and the Regional Partnership Board have been required to send in a report to the Minister at the beginning of this week on, as a consequence of our winter plans, which were overseen by the RPB, on what additional capacity we managed to open or additional care hours we were able to commission over the past 6 months, and how many additional hours and what additional capacity we are intending to bring into being by October this year in preparation for the winter. Of course, we'll have to plan the winter in addition on top of that. This is a very considerable priority for ministers, and we will be meeting with ministers in the next 2 weeks once there has been an analysis of the returns that have come in from the RPBs to assess progress and what more can be done and to share best practice. But it is a significant problem for the organisations, but most particularly for the individuals affected by delayed discharges. It's one of our very, very grave priorities. We've had 2 chairs peer group meetings on the 7th of June and the 5th of July, and we concentrated on the cost of living crisis, and we are producing a paper for ministers on our thoughts as health boards and health bodies on the consequences of the cost of living crisis for our populations. We have obviously discussed workforce issues, which are a major priority for everybody. We looked at the informatics programme and the new strategy that is being developed by DHCW. and how that fits with the progress that we're able to make in our own organisation. And I'm grateful to David for attending the Digital IM network meeting and providing us with such a comprehensive and helpful report as a consequence, because I think we need to meld these two much more than we have in the past, or been able to in the past. We also talked about the recruitment of both independent members and executives to boards in Wales. Everybody's having problems with this, which has left boards as our own with gaps, essential gaps in their ranks, which has put an onerous burden on independent members because they've had to pick up the additional workload. And we wish to be helping the Welsh Government's appointments unit to ensure that we give them plenty of notice, that we are very precise about what it is that we're looking for, and that we help them run a very slick and professional service on our behalf, because it has led to real problems. We obviously discuss social care and our plans. And of course, we have been discussing planned and emergency care, and there's more of that later on the agenda. I also chaired the Collaborative Leadership Forum, where we talked about trauma care and the results of the first year of the operating of the Major Trauma Centre. SARC, which is the Sexual Assault Regional Centre, which we have commissioned, and that will be in place in Cardiff, absolutely essential for health and well-being of sexually abused individuals and children. The future of the cancer and the cardiac networks and what their recommendations will be in their work programmes, and the radiology and pathology systems, which are going through reform at the moment. And we'll hear more about that later. I've had a number of meetings with the Minister. She visited the Grange earlier this month and went on a Monday at 11 o'clock and went through A&E and saw the new radiology department, which really is very, very impressive indeed. And we're drawing back work now from Bristol, which is a regional centre, because we have got such good capacity and so well-trained staff. And she looked at the new SDEC, the Surgical Emergency Day Unit. She was very, very impressed with that. She had a very long discussion with the A&E staff about the issues that they and patients faced. And we've had very good feedback from her. The chairs and the chief executives also met with the ministers later that week. She concentrated on building community care capacity, which is a keystone to our clinical futures policy. Urgent and emergency care, maternity services, to which we shall return, and planned care recovery. I also met as the chair's representative with the chairs of the expert group on the reform of social care, which is due to report in September. I think they've delayed their final report pending further understanding and further evidence. They certainly were very interested in the Gwent RPB and our ideas about social health workforce for the future and how we might go about achieving that. So that I know that they will be in contact with us further about how we're going to progress it. What do we mean by that, and what opportunities do we think we have? The Gwent PSB has also met where we looked at the well-being plan and the potential for being a Marmot region. We now need to see action. Exactly what are we going to achieve by when? And we also, of course, talked about the humanitarian crisis in the Ukraine. I have to say, the partners have stepped up as just as everybody did in COVID, and have responded really, really well to that crisis. I have met with the chairs of goodness me, I seem to have been doing a lot. Met with the chairs of Cwmtaf, Morgannwg, Cardiff and Vale as well. We meet on a monthly basis now to discuss improvements in regional working and the development of a work programme to deliver better ways of delivering some orthopaedic, ophthalmic and diagnostic services between those three health boards. We're making real progress in terms of ophthalmology, largely due to the persistence of Nicola, who has been the project lead for that. And I think, you know, we should be able to reach a conclusion in the very near future about the establishment of a regional cataract centre with some ophthalmology attached for the three areas there, by improving the timing of the service for people. I've met with the new LA leaders, both collectively and separately, which have been really helpful. I was elected as the chair of the Regional Partnership Board, and my first meeting was on the 27th of this month. We looked at the RIF, the Regional Implementation Improvement Fund, which has been agreed for 3 months because further work is needed on it, and particularly the evaluation of what worked and what it might not have worked quite as well as we wished. We approved the frailty budget, which is fundamental, and of course play a big part in our concerns about the frailty services and their reorganisation within Gwent, which James is leading. We looked at the governance reform based on the requirements, the future requirements probably to be placed on RPBs and their relationship with our NCNs and accelerating cluster developments. And we also looked at a winter plan update, but more work needs to be done on that. I've also done some visits, and particularly was pleased to be asked to the opening of the new clinic room in Usk, which the district nursing staff are absolutely thrilled about, and which provides a really enhanced service to that area, particularly to the rural community who otherwise would have to be visited, but now have a proper place where they can be seen. This was a real community effort. There was lots of resources raised by that community in Monmouthshire, and I was very pleased to welcome the first of the patients at the local individual, and it should really consolidate some of our community care. Good morning. Community care reform within the Usk region. So that's including all my other meetings, is what I've been doing for the past 2 months. Are there any questions? Now at the gallop, I'll put a note around. No, okay, thank you. Good. Could I pass on to 2.1, report from the Aneurin Bevan Community Health Council and Gemma? Thank you, and thank you for your report.
Thank you. Morning, Chair, morning, everybody. Apologies for the lack of CHC report at the last meeting, but you can see I've made up for the detail in this month's activity. At the top of our list is the standard pressures that we're hearing about in the Community Health Council at the moment, and the sustained pressure that we're hearing about with patient flow through the hospitals, access to ED at the front door, mainly for elderly people that we're hearing about on the backs of ambulances waiting to either come into the hospital for diagnostics to then go home or to be admitted. So we're hearing quite frequently of older people who are experiencing long waits and discomfort through that process. And it was really helpful for me to be able to see in the papers today that the 6 goals for urgent and emergency care is that the plan is in the papers today. So that's really reassuring for the CHC. Thank you. Interestingly, now that people appear to be choosing more wisely and well with their access to healthcare, we're naturally hearing about more access to pharmacies at the moment, which, you know, pre-pandemic world we weren't hearing a lot about. But interestingly, as more people are accessing their pharmacists and pharmacies for advice, we're hearing about prescription delays, delays on repeat medication, repeat prescriptions. So yeah, we're hearing now from primary care services across the board, but GP concerns seem to have settled at the moment, but that's not to dismiss or not recognise that the pressures still remain there for patients and the workforce. And we really welcome a presentation to our executive committee meeting tomorrow on community and primary care recovery and plans. So we still recognise the delayed discharge issues that we're seeing, and the CHCs across Wales are keeping an eye on Welsh Government reports where we've had the hospital discharge and its impact on patient flow through hospitals. So as CHC movement, we're really keen to see plans and responses develop to these reports. We have completed a dementia care in the community activity recently. Since my report was submitted to you, we have in fact submitted this report to the Health Board for your review and response. And I've noted some of the findings that people in the community felt that, you know, a lot of their support whilst they remain at home and leading independent lives in the community services could be a bit better for them. But in addition to a point that wasn't raised in this report, some people did say to us that there was some dignity and respect points that they wished to raise with us. So people living with dementia, not being spoken to directly by people and staff, and you know, people were speaking to their relatives or their carers instead. So they did raise a dignity point with us during this project, and the response from the Health Board is due in September. So we'd really welcome your thoughts on that. With the Health Board support, we launched our cancelled operations and procedures survey. I do have to offer enormous thanks to the Health Board for directly posting our survey out to nearly 2,500 people who in the last 6 months either cancelled or postponed their own procedure when the Health Board was able to offer them a date. As we thought, we picked up some issues that people weren't just cancelling because the date wasn't convenient, but people are feeding back to us that it does come down to some transport issues. People did cite work, childcare needs, and some people needed a little bit longer notice to be able to book paid time off work. So we were picking up some socioeconomic reasons why people are postponing their own procedures. One of them, one of the highest things that we found was, even though people are being offered dates, they are too short a notice. In some cases, we had 1 week or less, so people couldn't wrap their support mechanisms at home or in their social lives around that date, and then to have potentially a 6 weeks recovery time or longer. So we are picking out other things. So I'm hoping that this project will be really helpful for the Health Board and for us to understand and support people to access their procedures when they need them. Since I submitted this report as well, our Winter Patient Experience Project, the Health Board's response was due in July, and we have received that with thanks. So it's to note that we've got this report, this action plan from you. It was very detailed. It took on board all of the recommendations and the observations that we submitted, but this report reaffirms the pressures that we're hearing about at item 1 in this report. It was really helpful for us to continue doing this over the winter period, just so we could keep active listening and active monitoring of people's experiences during winter. Although I appreciate that winter pressures seem to be an all year round pressure at the moment, unfortunately. We've undertaken a dental mystery shopper exercise, and we have since submitted this report to you. So my team have been busy submitting reports since I've presented this report to you. What we did find with this, whilst we know that the dental activity and access to dental has not been slower, but it was more impacted because of the nature of the procedures that were taking place in dental with aerosol generated activity during COVID needing to stop. We actually received really good feedback from people when they needed to access dental in an emergency. So we actually had really positive feedback from people about that. What was less clear, since the launch of the new contract reform for dentists, from a switch from units of dental activity to a contract reform, people are a bit unclear about now what to expect from dentists in their community. So, you know, does the usual follow-up the usual follow-up timeframes apply in one practice, but now not in another. So we've just highlighted that as one of our recommendations for a need for further communication and supporting the community's understanding there. We've undertaken a GP exit survey. We visited 5 surgeries, forgive me, over the course of 2 weeks. We heard from a really good snapshot of people. 191 people spoke to our CHC members outside of these 5 practices. And lots of people did give us good feedback about access to their GPs, but again, access to My Health Online, and some inconsistencies in information given by one particular practice was noted in our report. So we've submitted that, we're about to submit that report to you this week. So we've just finalised the details of that report, so that will be with you by the end of the week. Again, I need to offer thanks to the palliative care team within the Health Board for chaperoning our members to patients within the hospitals who are in receipt of palliative care while they're staying in hospital. We did receive lovely feedback about the palliative care team's approach to people in hospital. We did pick up some environmental issues on Ward 44 at Neville Hall Hospital in terms of patient dignity and respect. We raised those issues with the Health Board immediately, and we were very grateful that that instigated senior level involvement straight away, and the implementation of senior nurse walkarounds and DECIs gave us reassurance that the dignity issues that we did find on that ward were resolved. So I'm really thankful to the team for being so responsive in that respect. I'm really disappointed to let you know that we were largely unsuccessful with our stroke services project, where we hoped to receive feedback from people who'd been through the hospital system after surviving a stroke and hearing about their experiences. This was supposed to run from November to January, but we didn't get any responses to our survey. It was in paper form and it was also online. We hand delivered the surveys to the stroke team, who did hand them out and even asked for more. So we knew that they were handed out on scale. But because of the low return, we decided to increase this project for 6 months until the end of May, but also host 2 Teams focus groups to invite people to give us feedback if they didn't feel comfortable to just fill out a survey. So we did have 8 people register to join us for a focus group. But again, then on those days, nobody attended. So we really struggled to generate any feedback here. And in fact, we only heard from 5 people at the end of 6 months. So what we've taken from this as a CHC is there's really no replacement for CHC members, feet on the ground, visiting hospital wards. I'm inclined to think that if our members had been able to visit at this time, which we couldn't, and we appreciate that, then we might have generated some more meaningful feedback. So we did put together a short briefing for the Health Board on the 5 experiences that we did get, because it is learning and those experiences were meaningful to those people. So I am sorry to say that we were a bit unsuccessful with this project, but we will consider a face-to-face visit to these wards in the future, just to keep on top of this. We did a primary care mental health survey with people, and we heard from 17 individuals. Again, the feedback that we received was largely not a good experience. People said the waits in the community were a bit too long. And in some cases, after a referral was made, either no action was taken after triage. And some people just found it quite difficult to access primary care mental health services. So our response was submitted to you in that regard, and we are awaiting the reply. We're hearing less from people now through our monthly feedback survey. We've got a national survey open to hear from people as the pandemic progressed, and is the NHS getting better after COVID is called now. We will look to revamp this survey because we think that people have disengaged with the word COVID, so they're not responding as well to our surveys as they were in the past. So we will look to utilise this this national survey locally in a more targeted way to hear from people about specific issues. So I'm hoping to generate some more feedback for you there. And finally, there's just some of our upcoming projects. We're doing a post-COVID, long COVID survey, and we're also looking to engage with people within the prison system within our area to hear their NHS experiences. So I'm happy to take any questions, Chair. We've been a busy team here.
Yes, I can tell that, and thank you very much for that. Any questions? Peter?
Thank you. Just want to comment really on the stroke survey. Thank you, first of all, for your efforts in trying to take that forward. Appreciate it's always difficult to get those responses. We have good CHC representation on our stroke delivery board, and I'd be happy to work with the CHC, finding ways that we can engage with patients and collect their views. So happy to work with you, Gemma, on that. We have a good patient reference group in Gwent for stroke patients. They are patients who've left hospital and are managing now in the community, but that might also be a source of information from the CHC. So happy to work with you, Gemma, in terms of that.
Thank you.
Thank you. Rebecca?
Yes, first of all, thank you for the report, as always, really comprehensive, and it's, I think, for me, it gives me a real window into some things I don't normally see. So I really appreciate the report. You mentioned very briefly My Health Online and some sorts of challenges with it, but you didn't expand on that. And I just wondered if you had any further information, or whether you felt it was something as a CHC that you should be asking people about their experiences with it, whether it's useful to them and what they use it for. I think because there's obviously you can make appointments or get prescriptions, but there's I'm not quite certain, you know, what use people are making of it. So it'd be really helpful.
Yeah, when we speak to people in primary care, it's a really mixed thing with My Health Online. Some practices utilise it for lots of different things, like ordering repeat prescriptions, booking routine appointments, booking, you know, bloods and access to nurse or even the GP. And others don't utilise it in that sense. They may only have a limited use for it. So people's understanding and need and utilising it varies from GP to GP, depending on how well that practice advertises the service to their patients, but also the amount of activity that a patient might be able to access and use it for. So I think for My Health Online, it probably would be a good exercise to understand each practice's method of using it and what they offer to patients, and then that correlating with then how much people actually use it and know about it. So it does vary from GP to GP.
And of course,
surgery.
And that can be quite confusing, I guess, if people move from one practice to another, they maybe don't get the same service. So, but thank you for that.
Thank you, Paul, and then Nicola.
I found this incredibly helpful, Gemma, and I think just an opportunity to say thank you to you and to your team for all the hard work in its preparation. Question is, the NHS Wales app doesn't offer the opportunity for repeat prescriptions, I understand, whereas the NHS England app does, and whether or not that's something we need to take up. I don't know whether that's accurate or not, but if that's what the one issue. And the second issue is on the people and appointments to hospital, etc. If suddenly there's a cancellation and then somebody rings up and says, are you available to come and have the operation? I think we shouldn't really criticise necessarily the system, but it may be what we need to look at is the opportunity to say, are there patients who indicate they can be available at very short notice or not? Because what we want to try and do is get patients into hospital to have the operations as soon as possible. So I think, you know, we need to look at how that can be facilitated to best effect, really. So I'm just wondering whether that may be a way forward so that people can indicate, yes, I am available at short notice for the operation or whatever's required, or I need longer time, because we want to try and get people through the system as quickly as we can.
I'd quite support that suggestion.
I think actually we already do that.
Well, for what they were saying,
I know,
Okay.
so we'll check it, but I know that that has happened. We'll just see if it's being maintained.
okay, thank you.
Yeah, it's just pick up on the My Health Online. So there's a national project called Digital Services Patient Platform, I think, which is about developing a new NHS Wales app. It's got kind of a dedicated programme director now, and it's got greater pace on this. I'll have to think about how we make sure we get a proper briefing to the board members on where we are with it. It's probably quite a critical stage of the project where we're trying to get the user group. There's a subgroup particularly about users, but that is initially focused very much on the primary care side, and some of our conversations is we've probably got more influence on the secondary care opportunities, so how do we bring those in as well? But that is intended to take over the My Health Online functionality where you can, and one of the things we've picked up is, you know, not all GPs actually have taken on My Health Online and offered the services, so that's another piece of work that's being done as part of that programme. So it has got a bit more pace. I think it's a ministerial priority around taking this particular project forward. So I'll make sure the board members are briefing. I think there's opportunities over the next few months for us to engage and influence. And again, Gemma, it might be worth taking some of the feedback from our members in terms of your members in terms of how we can feed into that programme to our services. But My Health Online will be then replaced by this new NHS app.
Because the issue I've got is that people were ringing to the GP surgeries for repeat prescriptions,
Yes.
and that causes more delay.
Yeah.
So therefore, if that can be alleviated by, and I think there's various apps you can put for repeat prescriptions, I think, just to make it much easier and simpler, then it takes that group of people who want to repeat prescriptions out to the system, so people who can access a GP.
And the whole point is this is supposed to be one app that you can go in and it'll enable you to do all of the different and access your own medical record, for example, your own medical record. And there are a couple of visuals that are being shared now, which help us kind of envisage what this looks like. So it'll be quite a useful session to dive on. James?
I'm just wondering if there will be an opportunity for us to link up representatives of our CHC with the Wales Digital Patient Programme. There's a huge amount of work being done in Wales, I think, so very high quality, looking at putting patient education for long-term conditions into a digital format. But I think it's very important that we make sure that those platforms are user friendly and that they are accessible by all members of our community. And I think as healthcare organisations, we have to make sure that no part of our population is left behind digitally if we're moving to mainly digital services. And also, I would want all of these electronic resources to be made available through one platform, because it's becoming an increasingly difficult area to navigate, I think, and input from service users without a healthcare background is actually incredibly important here, because the evidence from England is that some of these digital services don't land terribly well and don't have the impact on healthcare that they should. And I think it's an evolving area of research that also needs to inform the digital development.
Thank you, James. Perhaps you'd like to take that forward then, Gemma?
Yes, Chair, thank you. I just wish to confirm that the CHC movement was approached for a representative to sit on this this digital group to develop the app. And incidentally, my Deputy Chief Officer Linda is the CHC rep on this group. So we'd be really happy to link in with you locally on what we've heard and what we're feeding back as a CHC movement.
Thank you. David?
Just say the feedback from the Digital IMs group that happened last week was specifically looking at the issue around digital repeat prescriptions, the NHS Wales app, prescriptions in secondary care. I'll reshare my notes from that. But I think it's worth noting as well, because a lot of work connecting up with the Centre for Digital Public Services in Wales, looking to involve patients directly in understanding what their needs are around developing a that app. There's some bits around needs to change how the legislation is interpreted, because currently legislation requires or suggests that you require a wet signature. That there's been legal advice to the minister about whether that's actually needed or not. And the aim is to bring the NHS Wales app in line, at least in line, if not further than the NHS England app, so that people will be able to order repeat prescriptions digitally, as well as via the GP.
Good.
but I'll reshare my notes from that session with board members.
Bevan, and then James.
Just, it's not quite on the, it's
Oh,
almost
did you-
on the same subject.
Did you want to add to this topic, James, or is it something different?
Well, it was really to pick up on,
Okay,
just to follow on from Becca's question.
go on then.
So can I just check that the scope of ambition is greater than just online prescriptions? Because that for me seems very basic functionality that
Yes.
I would take as read that that's key.
It absolutely is. I'll share my notes with the board.
It's just a point on prescriptions, since this is the topic of conversation. My understanding is that people in England can access prescriptions posted to their home, and whether or not there's some functionality that we can enable, particularly for our population who find it difficult to get out to collect. Not all pharmacies offer a delivery service, so I don't know whether or not, as a kind of byproduct of these discussions, we should be considering whether we can do that.
We're in a position where it's easier to get your groceries than your prescription delivered
Yes.
to your home, and that's just not acceptable.
Yeah, I would agree. Okay. Thank you very much, Gemma. Is there anything further?
No, thank you, Chair. Thank you, everyone.
Well, thank you and your members for the huge amount of work that you're doing, and your feedback is always really welcome. Thank you very much. Can we move to 2.2, ADHD service for adults in this area? Chris.
Thank you, Chair. So the paper that the board have this morning outlines the current position where we're at in relation to providing a ADHD service for adults, and suggests a proposal for us to establish a interim service model for adults with potential ADHD. So I guess this area has been identified as a significant service gap within the Mental Health and Learning Disability Divisional IMTP. And in order to think about how we could address that, a task and finish group was established to consider the development of a proposed pathway. So that task and finish group includes representation from the Mental Health and Learning Disability Division, but also representation from primary care colleagues, so both from an NCN perspective and colleagues within the LMC. In order to inform the development of the pathway, a pilot was undertaken in South Monmouthshire. So one of our consultant psychiatrists in South Monmouthshire Community Mental Health team did a piece of work over approximately 6 months, and that provided very valuable learning for us. So the proposed interim pathway is attached for board members to consider, and it has been considered and supported by both the LMC and the CHC Executive Committee. It's probably worth pointing out what we've tried to do in the paper, but actually it's been quite difficult, is to try and get some sense of actually what will be the demand for this new service. So I think we're very mindful that because we've not had a service, we think there will be significant demand in the very early days. What we've tried to do is do some benchmarking, and benchmarking with other colleagues in other areas would suggest we're potentially going to have about 55 referrals to the service a month when it's fully operational and we get over that initial backlog of people being referred. It's also worth noting that we've also got approximately 300 individuals we've already committed to contact to inform them when the service is established. I think it's probably worth also highlighting that we see this very much as an interim service model at this point in time, and this proposal is based on what we're able to deliver with the resources that we have at this point in time. And colleagues may be aware of the written statement by the Deputy Minister of Social Services at the beginning of July around further resource to develop neurodevelopmental services across Wales. So we very much welcome that, and that's going to be an additional £12 million for neurodevelopmental services, all age, until 2025. So I think what we're trying to propose here is our first step, and then as we get additional resource, we'll be able to think about how that service develops and moves forward.
Thank you. Are there any questions? Chris? Paul?
Just wondering about the young people with ADHD, and then as soon as they become adult, what happens? Because there's a diagnosis of a young person, and I've come across in my career young people who've had medication for this particular illness or diagnosis. And it's like as if young people, yes, then adults. So what happens if you get the diagnosis, it continues into adulthood? Just
So
understand that really.
Paul, totally agree with you. I think that's been an absolute challenge for us to date. So within our children's services and neurodevelopmental services will absolutely consider whether children that are diagnosed with ADHD. And it's almost been like up until now, the person goes into transition into adulthood and the support available for those individuals has been sadly lacking. So one of the things that we've been really clear about in the pathway is to also identify whether it be that transition from people going through from children's services and adult services and how they continue to have shared care protocols.
Because the one issue that I can recall is the importance of medication. So what happens when somebody becomes 18 and the medication? So would the GP continue to offer that medication to the individual, or is it a sort of?
So in the pathway, we've absolutely established that now, that will be possible if we implement this pathway in terms of supporting that transition, enabling that shared care protocol to continue. So that would be a real benefit for us.
Right. It just seems a bit odd that suddenly there's a cut-off point.
Oh, it's been.
And I know there's significant resources from the state available, I think, from the benefit side of things with ADHD, because when I was in the youth court system, I think it was a recognised disability which allowed a resource element to support the individual with ADHD. So any delay would mean a delay in any some sort of financial support as well. So I think just for us, this is an important area of activity for some of our vulnerable people in the community who may be struggling with this. So there's other implications to this, not just the fact that there was the medication and potential access to disability benefits and support. So
and I think probably where we're wanting to go for it as the service develops and we get additional resources, it's thinking much more about the wider intervention support. So in terms of being able to support people to be able to access support groups, voluntary sector support, broader multidisciplinary interventions with people, psychological intervention, occupational therapy to support people to think about work and employment opportunities. You know, I think there's a long way for us to go. I think this is very much the first stage of trying to develop that service.
Tish.
Very much welcome this. This is excellent, and it is difficult and scoping and so on, but that's not a reason not to do it. It's absolutely right step in the right direction. My apologies to David actually, because we were talking about this earlier and it was on my list of questions to ask, and I know it's on his list as well, but I got in first. In respect of the pathway, and this is a specific point, and Nicola's used to me asking questions about WCIS and EPEX. I'm just wondering if we're confident in our back office systems in this regard, in as much as we are transitioning. We wouldn't want to lose people or you know, what happens, what's our kind of fallback plan, as it were. Just know that we're in a kind of area of moving on.
I think we are with all of our system, aren't we, actually? So I guess it will be the same sort of process in terms of transitioning from EPEX to WCIS for this pathway as with all our other transitioning people to that new pathway.
Yeah, we've had reassurance from the programme team that the service will migrate from EPEX onto WCIS, and as part of that, part of the programme, the service is identified in there and will be migrated over in the same way as all the others.
Everything. Okay.
It's just briefly, and I may have missed it in the paper, so I apologise if I have. But because it's a new service, I'm assuming we're going to evaluate it to make sure that it's working well. And I just wondered what the kind of timeframe on that was. So whether we were going to be trying to assess it in 3 months, and because obviously you're a bit, it's a little bit of I'm going to go with guesswork. It's not quite the right word, but estimation. That's the word I'm searching for, of how many people you're going to be dealing with. And there's been quite a lot in the press, hasn't there, about celebrities who are being diagnosed and whether or not we think that's going to have any impact on the general population seeking a diagnosis.
And I think through the evaluation, I think there's a number we want to look at. We want to look at patient experience, patient outcomes, and also that broader understanding of what is the potential demand condition. Yeah.
Thank you. David?
TJ obviously got to my main question I wanted to ask, but the other one was related to the backlog that we're expecting to grow, and the paper calls out the fact that we're likely to build up quite a significant backlog of people to assess. I'm keen to understand a bit about how we might keep people informed, updated on how that backlog is working, so that we don't end up with people being too frustrated but they're having to wait a substantial time for their assessment. How are we going to manage those expectations?
I think that's a really important point, and one of the things that we're trying to do and the team is trying to think about now is actually what opportunities are there to provide people with information whilst they're waiting. So, you know, are there opportunities for us to be able to providing a nice, easy read information about this is where you might be able to access support from the third sector. These are some things that you could be doing in terms of self-help if you feel that you might have a diagnosis of ADHD. So I think that's going to be really important about how we manage and support people whilst they're waiting.
Thank you. Are there any further comments or questions? Are you happy then to support the recommendations? Thank you. And we look forward to having the report back through the relevant committee on the success and the challenges of the system. Thank you. If we move on to section 3 and 3.1, the 6 goals for urgent and emergency care. And I think Nicola, pardon?
I think, yeah, if you want to give a brief intro,
Yeah.
Chris is going to take the lead.
Okay, thanks very much. Thanks.
Thank you.
Okay, so the board will be aware back in June that we received a paper on our approach to the urgent emergency care services and the 6 goal programme that has been set out by Welsh Government. I think quite importantly, it was important that we brought the actual formal plan that we submitted to Welsh Government back to the board, which is what we've done today. We had to submit it to Welsh Government by the end of June, so we've done that. But obviously, as I say, it's really important the board has an opportunity to look at the formal plan that's been submitted. So you've got the paper here today. Probably just a few things to sort of outline, and then I'll perhaps hand over to Chris to sort of add some further points as well. Really important that the programme arrangements are led and chaired at a very senior level, given the importance of this programme of work. I think the 6 goals allows us to look at patient pathways in a very clear way, looking at things like prevention all the way through to discharging patients from hospital. And I know that we'll discuss some of those elements in other arenas as well. So what we've tried to do is mirror some of the 6 goal arrangements at a local level, so that actually there's that clarity between the national work and the local work, but I think also trying to maintain the focus locally on what we think are our priorities. So one of our MTP priorities is around the redesign of older people's services in terms of cognitive frailty, and therefore really important that the work that we do locally doesn't duplicate and is effective in improving outcomes. It's probably worth also mentioning that at a national level, there are some sort of key enabling areas that Welsh Government have recognised are really important we get right across NHS Wales, and this looks at things like communication and engagement, but also that wider behaviour change amongst public and health professionals in terms of how we deliver care. We've talked a bit before about digital and information, and again, really important that there's a standard approach across Wales for this programme as well. If you go through the national handbook, you'll see there are quite a lot of areas that we're going to be measured on, quite rightly, and I think one of the things that came out of the CHC report is how we're doing in terms of patient experience. So a lot of the performance targets that we measure around access suggest that, relatively speaking, we're doing, the model in our health board area is working relatively well, although not well enough. But what we very often struggle with is patient experience. So really important that we measure and improve on patient experience as part of this work as well. I think it's probably fair to say that a couple of the real sort of priorities, particularly this year across Wales, will be around establishing urgent primary care centres and also the SDEC, or the same day emergency care unit. So again, our plan sets out what we've already done in the health board area. So board members will be aware that we already have urgent primary care centres in the Royal Gwent and Neville Hall hospitals, and our main SDEC unit in the Grange is due to open in August. But the aim will be to sort of build on that model across some of our other hospital sites as well. So again, I think we recognise it in our plan, but we're already making progress in some of those areas. I suppose the final point I just wanted to make really is I think it's really important that the approach is across not just the health board, but our partners. And this crosses some of those traditional boundaries of primary, secondary care and some of our divisions. So really important that actually we see that in action when it comes to delivering improved patient care. So I think those are probably the main points that I wanted to sort of cover. And Chris, I don't know if you want to add to that.
Possibly the only thing to add into that really is just picking up on your latter point. So the plan has been submitted to Welsh Government, presented at the beginning of August. We've had some informal feedback from them in relation to our submission. And one of the things they welcome is in terms of the range of potential leads we have across the goals and across the programme. And they very much have noticed and identified that that's across professions, across agencies, and that's something they've identified that they welcome. I think the other thing probably just to pull out as well that is already mentioned is, in addition to the metrics, the piece of work that we will need to do about how we capture patient experience and how that sits alongside the metrics to inform improvements as we go forward.
I thought we had agreed before I open this up to improve the collection of patient experience. Where has that got to? Because that must have been 3 months ago.
Are we talking about the Civica system? I think
Well, whatever system it was, and they
so that's being implemented by
Yeah,
this.
yeah, it's been led by Tanya Strange from the team. If I can get
Perhaps we could have an update on that then, please, Linda.
Absolutely.
Circulated to the board. Thank you. Any questions on this? Shelley,
Sorry,
I'm
I'm
Helen.
I've just going. I think it's a great plan and it's well set out. My only concern is around some of the risk areas. So if you take goal 3, a lot of that is about required funding. So I suppose my question is, if that funding is not forthcoming, obviously we've got other papers that we discussed today. What's the plan B going to be so that we can make progress if we possibly can in these areas?
So, I mean, I think in terms of risk around funding, I mean, clearly it will come down to prioritising. But I think I would say in terms of urgent and emergency care, that has to be one of our key priorities as a health board. As I mentioned before, I think although we're doing relatively well, if you actually look at the performance targets that we measured on, we're not anywhere near what the national targets, which suggests we should be performing at. And I think we've already heard about some of the patient experiences that we wouldn't want happening. So I think there will need to be a discussion about priorities then if funding becomes an issue. I think it's important to say that we've already implemented some of the priorities. So urgent primary care centres have already been implemented. The SDEC will be implemented and will rely to a certain extent on reorganising some of our workforce. So it's not necessarily a case of recruiting significantly more doctors and nurses, for instance, which is something I think we would find challenging anyway in terms of having the workforce available. So, so I think some of those key priorities we're already well on track to deliver.
And then Phil.
Chair, I think my question was very similar, really. Obviously, some excellent ideas of things that could be taken forward. But again, it was the risks regarding funding, even for services that you've set up. So I think, you know, your respiratory ambulatory care unit, and then the risk was continued funding, isn't it? And staffing. So yeah, very similar concerns, but great ideas, and hope we can take them forward. Thank you.
Thank you. Phil?
Yeah, thanks, Chair. I think this is a great plan and really good to see it. I think really this will be one of those kind of pillars to improvement, I think. So I think a lot of what we do will come off this plan. It feels very much a health plan, and I guess primarily it is, although there's a significant chunk of it in terms of the success of it, which will depend on the whole system issue. And particularly, of course, you know what I'm going to bring up is the social care element of it. I don't know what involvement social care has had nationally with Welsh Government in terms of the outline plan anyway. I mean, one of the significant targets, of course, for the whole system would be the 48-hour one. And I've not heard any discussion in the social care circles that they are in any way signed up to the 48 hours, or I've not even heard the discussion. I mean, 48 hours, once you decide that someone, for example, is fit to go home, is going to be an incredible leap for the whole kind of out-of-hospital system, particularly when you look at our current performance. So I think there's a hell of a challenge within there, but I think it's the right kind of challenge. But then when you look at how we implement all of this locally, I just wonder whether a representative of social care or our board to implement this, for example, is probably right. If you're a sole social care rep coming into this system, it can feel a little bit overwhelming, and it can really endorse the kind of health issue that this is a health idea, it's a health plan, and social care are being invited to what it could be classed as another health party, really. So I think perhaps we need to look at that. I mean, I would think there would be merit if we could get somebody to do this. I mean, certainly if I was a director of social services now, I would be putting my hat in the ring to be a co-chair of our board on this, because I think social care is that fundamental to it. I'm not sure that in our part of the world people would want to do that, but I just think that it's going to be essential that we develop the social care elements. If you look at the way that our plan is developing, it's quite rich and quite detailed in some of the things that we intend doing, but it's extremely weak in terms of what we intend actually doing in terms of social care. And I think that reinforces the point, really. But I generally think this is a really good step in the right direction. But as ever, the proof of the pudding would be in the eating. But generally, I think it's very good. Thank you.
Thank you, Phil. Anybody wish to flip the paper?
Yeah, I think it's I really like the way it's set out. I think it's very clear, and I really welcome that. There are obviously a number of things in here which are still to be sort of organised, and I wonder, for me, I would find it incredibly helpful to receive this on a regular basis, with it being regularly updated, so the risks are regularly updated, and then some of the timelines that we don't yet know about are regularly updated. And it's a nice format, and if we've received it in a format that people welcome, and it's easy to read and it's the right kind of high level, then I kind of feel that having something that we know that we can look for the changes as they go along would be really helpful. Of course, not everybody may agree with me, but for me, I think it would be useful.
Shelley?
Sorry, could I ask another question? I
Yes, can I just
certainly.
I actually agree with you, because I think it's really, really important that we are very clear about the content of the goals that we're trying to achieve, and the measurement of what makes a difference to people and their experience. And I like the format. Now we have to flesh it out a bit more. so that we know what is going to work, and we have time to adjust things that haven't gone quite as well, but so that we share this venture together. So I would agree with that. Thank you. Shelley, and then I saw somebody else's hand. Oh, Paul, and then Tish.
And again, that's actually what Pippa says is part of what I was going to say. I was looking at goal number 5, and I think my concern there is that there's a lot to be, and also 2022. My question was, what would the impact of non-delivery in this area, because this is key, how will that affect the rest of the plan? Yeah. So I think your point, and I suppose about us have a regular update about what we're measuring and actually what we want to achieve is key. Yeah. And this is so important. It's such a priority in terms of, you know, not only for ourselves, obviously politically. You know, I think monthly updates, if that's possible, would be helpful. Could I just ask another question? Because we've mentioned directors of social services, and we normally should have, or we are supposed to have a representative on the board. So yes, I wondered whether or not, do we have a name? Because I'm, you know,
no, we don't have a name at the moment. Yeah. We have asked for it. You know, most of them are brand new, and we are speaking to the collective to try and encourage something. Yes. Paul, and then Pippa.
I mean, with so many plans, you can hit the target, so you can miss the point. And the only disappointment I've got is that it doesn't say whole system approach, because if you hold into account, who is being held to account here? Because it seems to me there's health.
Yeah.
There's nothing in this saying that the whole plan will be monitored by, say, the RPB, and that people will be held to account to make sure they've hit the target of being completed. That's the only thing I think I just find slightly disappointing, I suppose, because the plan, I think, the 6 goals, is really good. I've read the document and I've looked at the headings, and they've got targets and all sorts of things at the bottom. Then I'm thinking, we'll be monitoring this, but will a group in the council or the social services be looking at this and thinking, are we delivering what we've got to deliver? And I'm thinking, probably not. This is another siloed health model for us to follow. Just wondering how this can be used, you know, across the system.
Nicola?
Yeah, so just picking up 2 points that have come up. So one, in terms of the ongoing monitoring, we've got really good program management support.
We have, yeah.
So we can absolutely make sure, and this will be a key feature on our monthly clinical features program overview, and we can share that. So more than happy with that. I think your point about what we've got to do is the read across of this now to the RPB priorities. And I think we need to extract out of here the things that we know are absolutely need to be the RPB priorities. The same when we probably will talk about the COTI plan.
Yeah.
You know, where when we go through our priorities, there's a reliance on other partners. We need to make sure that they fit. So when we clarify the RPB priorities with Anna in the chair, we need to make sure we've extracted those that we can't deliver on our own, and absolutely, and we do that accountability through the RPB mechanism. Yes, not through our internal urgent care plan. It's history.
I'm just wondering whether there's one plan with a golden thread that all the other plans, you know, link into it, because otherwise you've got plan for this, plan for that, plan, and it's all plans rather than one plan. You've got the IMTP. How does this fit into that, for example, which is going to be our one plan?
Yeah, so I think our one plan as a health board is the IMTP, of which this is a top priority. And there's lots of things in here that are in our gift, but there are lots that are relying on partners. So I think we do then need to have 2 plans, which is an RPB plan. Well, there's 3, isn't it? The social care will have their plans, which will be things they do without our requirement. There are things we do without their requirement, and there's things that we have got to do together.
Exactly.
So I think if we just recognise there's probably 3 plans, but the one that we're most concerned about is the middle one.
Should they one plan 3 parts?
3 parts, yeah, you know. But that's how I see it. We've got to just be clear about how we do the accountability of all the things that we need to do it. You know. And I think there's a piece of work nationally as well around how we are pulled in together, and we're not having a health discussion all the time about the 1,000 bed days that's not in our control.
Exactly.
Yeah, so that's a more broader issue.
Oh,
thank you.
Did you want to add to that, Sarah?
Yeah, it's just on, if I may, Chair, because we've got to approve the RPB area plan by next March, and we also haven't concluded how we're going to spend the 5-year funding. So there is an opportunity this year to be, there's the learning from what we've done locally, what worked, what we might think we want to continue. But I don't think as part of that area planning process, we've done the alignment with the urgent care goals. Because we need to pull it together, don't we, to have the one, the area plan is the plan.
But I'm not talking about next March, I'm talking about now.
Yeah.
So there's a difference, isn't there, in terms of longer term versus this is what we'd expected to happen now before the winter. And therefore, how do we get some of that agreement and accountability on?
So that there is we have to sign it off next March, but the process of writing it should be now. Because we did the P&A, the population needs assessment, which we received. We're now meant to be in the middle of writing the plan for the next 5 years. But what I'm saying is that process is separate to any consideration of this.
But hopefully this
But
will
it
be
needs not to be separate.
Yeah.
And we haven't seen the other part of the plan, which is the local authority plan, which is solely theirs.
Yes.
And that's got to come into the
Yes.
mix. Did you want to add to that, James?
Yes, and it's really to endorse what's already been said, that I think I'm the executive responsible for the redesigning the services for older people project, which is a kind of stakeholder in all of these groups. And I would say that the kind of single point of failure I'm most worried about is that linkage between social care and healthcare, because the aim of the aim of the service that we're trying to develop is that anyone threatening admission will get an assessment in their own home within 4 hours. And at the moment, we only achieve that in 34% of cases. And we probably only see about 20% of the people who may potentially be eligible for that service on the basis of the data we have. But one thing that's become clear is we're trying to put in place healthcare input within 4 hours, but actually a lot of those people with healthcare needs also have self-care needs that will require social services to be as responsible. We're looking at what we can do within our own service, what we can do with the third sector, and what we can do with social services, but the link is not good enough yet.
Yeah.
And the steer that you've given us, Chair, about the way in which we work on place-based commissioning with local authorities, I'm getting a lot of advice from Chris in these areas where he has much greater expertise than me. But it is absolutely key, and it is probably that interface will be the single thing that determines whether our service is successful or fails ultimately.
Thank you, James. Tish?
I won't repeat what everyone else has said, but what Nicola said. I mean, the summary that you gave there is absolutely where I am. I'd just like to reflect a little though. So we're talking about urgent and emergency care, and traditionally this has been absolutely our domain. You know, this is where everybody looks to health. They look to hospitals, they look to ambulances, and whilst there is an enormous body of work to do that we all collectively need to get behind, if you reflect on that, which really was the kind of narrative not so long ago, and now we've got a plan that actually is getting to the point, which is that this is a whole system approach that doesn't just rely on our system, but much wider than that. Absolutely agree with the issues that have been talked about in terms of resourcing, but that also then extends outside of this organisation to partners, both in the statutory sector and the third sector. And I know Chris, you're very signed up to working with the third and community sector. So that's something that we need to be very, very realistic about in respect of engaging with our partners to deliver on this.
Are there any further questions or comments? Okay. We need to take forward pretty urgently a number of actions in respect of the engagement of our partners, without whom we cannot achieve some of these goals. I will certainly raise the issue now with the RPB in respect of the area plan, which is long-term, and the immediate action that we need, because we have to still reach a conclusion with them
about the bed equivalents, but more importantly, how do we effect a real improvement to intervention at a community-based level to avoid unnecessary admission and then repatriation, and to provide a better range of care for individuals within their home environment and wherever that might be. So I think the RPB and the partners are absolutely key to this. We certainly have to secure a better understanding of the resources that might be available to support this. But we will have to monitor this very carefully, because adjustments will of necessity be made, depending on the answers to a number of the questions. But I should like to thank the team very much for putting this together and reaching a sound plan in such a very, very short period of time. Are we happy to endorse this plan, and are you content with the action that I've outlined? Yep.
Okay.
Okay, thank you very much indeed, and thank you team for that. The Q1 outcomes report. Yeah, Nicola.
Yeah, thanks very much. And it's been quite a challenge putting this report together in a new format, recognising the ambitions of us as a board to move towards a more outcomes-based reporting than traditional performance. I will welcome some feedback, particularly of probably some more longer conversations outside of the board meeting on this, because I see it evolving over future quarters. A couple of things that I just wanted to reflect on myself. So the minute is broken down into 4 sections. One which is trying to align outcomes to our 5 most priorities that are in the IMTP. There's the progress against the clinical future 10 priority programmes, of which we've just been talking about one of them. And the last section is the quarterly expectation by Welsh Government that we update our minimum data sets in terms of some of our deliverables. So it's trying to do 3 things. And some of my reflections is, are we making it too complicated because we're trying to do proper outcomes and traditional performance? And one of the things I'd like to get views on outside, as I said, is should we try to separate those that are more traditional performance metrics versus those that are true outcomes? And the other reflections, and I'm sure you'll have those as you go through, some of the real outcomes, the information is quite outdated, and you can't get a live quarterly update on, you know, the weight of the children in your community. That's not something that's produced quarterly, and some of those metrics are even captured every 5 years. So you need to think about the value of those metrics. So timing is quite an issue with one of them. The new NHS, we had guidance earlier this year around Welsh Government outcomes, which we've tried to build on. There was about 30 of them. There's a new performance framework come out at the end of June, which has now got 84 metrics, the Welsh Government. So I think it's useful to take those and think about which of those are proper performance, which of those are outcomes that we want to put in this report. So that's been some of my reflections, is am I trying to do too much in one report that then loses your message? So I just wanted to kind of pick up that. And the other bit, which I think we've already talked about, is how do we, as we get the new patient experience system in, how do we bring in patient experience and feedback much better into this report once we've got that information? And the quality and safety piece, we put a couple in there, and there's a huge amount goes to patient quality and safety committee, but what should be in this overarching report? So they are the areas that we've not got right, but we've made a first attempt at in this quarterly report. So that's kind of my, and giving the answers to some of the questions before you raise them, because I feel the same. So just in terms of the headlines, and I'll try not to spend too much time on it, but we've picked overall 40, there's 43 kind of outcome measures we've been looking to focus on, particularly for this report, of which about a third shows that we're improving, about a third shows we're deteriorating, about a third are similar or we can't get the data for. So again, I'll just, under priority 1, particularly around good health in pregnancy, is showing some good improvements. Optimising a child's long-term potential. Some of our breastfeeding measures, again, they last quarter, we would have been right in the middle of the winter. They're not looking as good. It's probably not a reflection of Q1. And some of our childhood immunisations, generally we do quite well and we maintain that position. So maybe some headlines, recognising there's more detail in the report. Under priority 2, I think in terms of improving mental health resilience for children, we know our neurodevelopmental target is not delivering to the level that we want, but there are plans in place to improve on that position later this year, and I know we've shared that in previous performance reports. I think supporting a healthy weight for children, you can see in some of this, the data's just not there, or it's very old. So it's quite a different, but it is something that it keeps our focus on it, and how do we try to capture more up-to-date indicators on this. And then improving healthy lifestyle behaviours, again, shows similar positions, but again, latest data is 2020. So I think it's quite good because it's making us think about the things we want to measure, but it reinforces how data is not really prompt in terms of giving us what we need to know, particularly on a quarterly report basis. Some of them lend themselves to more of an annual. Priority 3 is where the most information is and the more familiar areas, particularly around adults living healthy and aging well, particularly around maximising an individual's time. These are the ones which government measure us the most on, because they're the most quickly, routinely available. And as you can see on that, I'll pick up plan care in a bit more detail in a second, but you can see there's some quite good indicators around the increase in urgent primary care, given what we've just been talking about, and using 111, we are seeing improvements. I don't know if they got them far enough, but they are going in the right direction, which is good. Our urgent care system, they're fairly similar, but it's showing a broad deterioration. It's not improving, and we've just been talking about all those issues under the 6 goals. And then I think in terms of adults living and aging well, and some of the smoking metrics and so on, again, the population health metrics we don't get routinely, but are improving in terms of the latest data. But it'd be interesting to see what the pandemic potentially impacts on those as we get the latest data during this year. So they're kind of the main, and cancer in particular, maximising cancer. We know we've seen a deterioration in our delivery against the 62-day target. And it is a particular challenge for us at the minute with the increase in demands we've seen for some of our tumour sites, and the workforce challenges we've been facing. Even though our last data on cancer survival, primary cancer survival, is going in the right direction. But again, it'll be interesting to see how that now gets impacted as a result of the pandemic. There's a particular, we've tried to pull out the more planned care targets, and I'll pick this up in a bit more detail under planned care under the next item. But you can see in a number of areas, we've tried to show how we did against what we said, and that's what we've tried to do more. What did we say we were going to do, and have we delivered against it? And you can see a number of our metrics we've done better than expected, particularly in our 104 weeks for treatment, and as well as some of our 26-week weights. We've not done quite so good on endoscopy, even though we've been improving, and some of that is because of the extra demand we've been seeing, cancers as well, which has taken some of our planned capacity. But we have got a lot of plans in place to keep improving. Moving on to priority 4, and it's quite good in terms of the common themes have already come up on this. Some of this led to self. So this is about how do we measure if older adults are being supported well at home, and I think James just referenced the rapid response within 4 hours. So they are the type of metrics we try to capture under here, and you can see that it's broadly says deteriorated slightly, 35%. How do we start monitoring symptoms? And what it also shows is our shorter stay, patients' length of stay is improving, but our non-short stay are staying much longer, and this is the metric that shows our older people are staying a lot longer in a hospital, which fits with the narrative that we're familiar with. And then finally, the one where we're trying to look at how we're making sure we're respectful, and now when people die that they are done so with dignity. And there's a few metrics there that we are developing, but also just looking at medical certification and that provision of end-of-life for palliative patients, both of which have shown an improving trend at this point. But again, these are the metrics we probably can try to capture more softer, particularly looking at the death we've got in place, that really just helps give us that assurance that we are compassionate at this stage of people's lives. There's a little bit, as I mentioned, on quality and safety. We've just put our position around infection control. C diff we're not doing as well, but all other metrics we're pretty much doing in line with our target and generally better than most other health boards. And this is the area, and again, it'd be useful to think about what do we want in the overarching quarterly report versus what we drill down to in the Quality Patient Safety Committee. We just pulled out a couple of the key workforce metrics, particularly some of our, the amount of money we spend on temporary agencies and all the workforce, which, whilst it's around 6%, we know when we add some of the COVID data and those medical exclusions, we're more around the 8% now. So it's still a huge challenge for us on the ground in terms of workforce. So they were kind of how we tried to align the outcomes performance to the 5 life courses and quality and safety in particular. There's then quite a lot of detail against each of those 10 big priority programmes, which you'd be pleased to know I'm not going to go through. When I've gone through them, I feel that the board is relatively well briefed, and we've covered most of those areas at some point over whether that's the NCN, the urgent care, planned care. I think the big ones for me is around that urgent emergency care, and as James said, our redesigning services for older people. That's where we see, and that's particularly where we've got that real interdependency with our partners. I think the big focus for us now, we've now got a kind of monthly beat as an executive team against each of these areas in terms of monitoring how we're doing. And I think we also really trying to look at how these big change programmes can help us support our financial sustainability this year and beyond. And I think they need to become a bit more focused around the contribution they can make to our financial challenge that we'll be talking about later. And then the final section, which is around how we doing against what we said we did around some of the key modelling we've had to do around demand and activity. And I think some of the key headlines shows that referrals are now back within pre-COVID ranges, and we've not seen the increase in referrals to the level we did predict could have happened. So, which is good at the minute, but we just need to keep an eye on that. We've seen increases in the numbers of first outpatients, so that's quite good that we are getting an increase in our activity. We're not seeing the same increases in elective and day cases as the increases we've seen in outpatients, but we know staffing is a bit more of a challenge there, but we're working on that. And our bed occupancy has been, really at 97% across the board, which is not a great place to be in terms of running an efficient system. So they were a couple of things worth drawing out. In terms of the things that we've changed, in terms of going from quarter 2 to 4, which is key that the board understands and supports. So we've made improvements in our 104-week wait position, which I will pick up into plan here. The 104-week wait for treatment by March, the Minister wants that to be 0 in most specialties. We're not there. We're going to be about 2,400 at this point in our modelling, but it's a big improvement from what our original one was, which was around 8,900. We already improved it to 6.5, and we propose we'll improve that further. Improving our 104 weeks for an outpatient as well, and also increasing the number of outpatients that we will entertain. The areas where we are projecting we won't be as good as what we'd said in the first draft, which is around cancer performance, because when you've got a huge backlog, while you treat that backlog, your performance will be poor. So you almost got to, you have to go through that kind of phase really. And also endoscopy, based on the increase in demand, that's not going to improve at the rate with which it originally was. And then the two areas we've kept the same, but we are going to keep an eye on is A&E attendances. We're above the forecast level in Q1, so we're just going to do a bit more monitoring of that. And also we've assumed our elective inpatient and day case activity will be the same, but I think we know it's an area we are hoping to improve on, but we're going to use quarter 2 to do some more review. So they were just the ones I was going to bring out. Other than primary care, there's some quite useful messages in there in terms of where we have seen some increase in our GMS activity. We've seen greater use of the common ailments scheme in pharmacy, and more referrals to some of the things like urgent assessment for rapid response. So I think there is an indication that we are seeing some of our initiatives working, albeit to a smaller scale than what we need. So I'll leave it there, so I could talk about the report for a long time, but hopefully it does give you a flavour of how we're doing against our plans in the first quarter, where some of our pressures are, and I'll talk a bit more about the plan care targets under the next item.
Thank you. Before I bring Pippa in, could I ask, do the officials that are going to monitor our performance on this understand that much of our performance actually depends on other agencies over which we have limited control? Or
I do think they know that, but I think the pressure is back on us to go and work with partners to address it. Okay, and that's for us to sort out as well.
It is. So, Pippa.
Thanks. Really comprehensive report, and I guess if there's any sort of details, as you said, we can pick those up outside. I just had one question, and it was about the 95 to 97% of bed occupancy, and obviously that's above our forecasted or our expected levels. But my question really was, It's not so much about what the forecast is, but what we would like it to be in order for our system to run in the most effective way. And I don't know what that number is, and I just wondered if.
I think well, it varies for specialties, because it depends on the volatility, but generally on a, James can correct me on, but generally 85% is considered the optimum occupancy. I think our plans have been, it'd be good if we could get to 90, because let's be realistic about what's achievable. And what we see is variation, because sometimes when you look at the bed plan at a high level, and you think, well, the beds look like they were in the number we predicted. When you take peds out or obstetrics out, which needs that, they have much lower, average occupancies because of the volatility, and surgery out where it's influenced by elective, and it's the medicine and the community beds that have been running at probably more than 100%. We've had to open surge capacity. So the average comes down, but we know at a specialty level it is much. But 85% is the optimum. 90% would be nice.
Yeah, but 85 probably isn't being achieved anywhere in the UK.
No, it's a platinum.
It is, but it's real, because it means that we're unable to respond in the way we would like to surge unexpected surges in demand like COVID or flu. But it also means that infection control then becomes very difficult. It's very well recognised that once occupancy goes over about 80–85%, infection control becomes harder and harder to manage.
Thank you. I was really just for clarity, because I don't think I'd ever come across the figure.
No, thank you. I'm glad I got it right, Jane.
You did. Yes. But if you imagine for the teams what it's like working with bed capacity of over 100%, it means that sometimes they're having more than one person through a bed space in a day, and the work required when a patient's admitted and discharged is kind of front and back loaded. There is a huge amount of work for already overpressured nursing staff. When you admit someone to the ward, do all the assessments, clean the space, communicate with family of people arriving and departing, that is hidden in those figures. That is what's really it.
Any further questions on this? Richard?
Just comprehensive. I think you kind of made an apology at the beginning for the length of it. I think it's the length it needs to be. I think no apology is needed. I'm certainly informed after reading it, and look forward to seeing it in the same format. How you get that on the page without using the Hubble telescope to read it, I really don't know. So what I'm about to say probably will be petty, and I apologise in answer it. On the horribly titled Dying Well section, there's reduction in complaints and the increase in the number of advanced care places, indicators to be developed. If you're looking for a reduction and an advancement, am I being naive thinking why would it indicate it? Surely you've got a set amount and then you reduce it. I just don't understand why we haven't got the indicator in place there.
I'll follow that up and find out exactly where that is.
And if I'd read it in advance, I would have written to you. Sorry.
So, no, it's fine. And it's fine. I can make sure we follow up. They can talk questions, and there's probably a very valid reason for it that I can't answer quite now.
No, thanks.
Yeah, likewise, I think it's an excellent report. There's an awful lot in there. I did read it in advance, it took me ages.
I read it 4 times last weekend, kept sending it back, sorry.
Just to answer your a question that you posed at the beginning around outcomes and whether they should all be, I just think it is a journey, and we've got we can't let perfection be the enemy of good, and I think this is a good step forward, because that's what we should be measuring is outcomes. The fact that we also have to, for entirely appropriate and understandable reasons, we have to measure and present performance information is that's a related thing, but this is where we need to be going, because actually that's what matters. And if that then informs those performance measures in the future, because we discovered that right, whether that's at a health board level or on a government level, then that's all good.
Jane, can I get back in?
Yes,
certainly. So I completely agree, and that's what the way, you know, you've taken it in terms of we just keep trying to improve this. The bit that I didn't probably cover is I think it'd be quite useful to pick some of the the big conditions that we might want to, where there is quite a lot of clinical data and outcomes, and I'm also conscious stroke isn't in this report, which is quite evident. But you know, stroke, cardiac outcomes, diabetes maybe, where we know there's lots of different metrics that indicate outcomes. But again, think about how frequent we might want to draw attention to those, whether it's monthly, quarterly or annually. But I think that's another area where I'd quite like to get into a bit more clinical specific areas where we know there's some good data.
Thank you. Sarah and then Rob.
It was just on the subject of outcomes, because there's a distinction between outcomes from a healthcare intervention and population health outcomes, which are long term. And I think with the healthcare outcomes and all the work around patient reported outcome measures, I remember the data on the post-cataract surgery that was presented to us, and what matters to patients as well, how well they can see. And that was variable. So I think that that's really important outcome from healthcare, but population health outcomes take much longer. So in the world of population health, once you've got a proven intervention, like we know giving up smoking will prevent cancer, measuring the proportion of your population who are giving up smoking is actually a more immediate measure. Right, because you know the impact on cancer incidence is going to be 20 years down the line. So I think we call them process measures rather than performance measures. So the process measures are actually quite important in terms of population health outcomes.
And I think I totally accept that, and I think that having, if you like, the three levels, so the process measure, the clinical outcomes, the patient reported, and then the population health, we need to be triangulating that, surely, to inform the way that we deliver in our strategy going forward. So it's a
and the population outcomes in the early years, which are the most important in terms of long-term health, are actually quite quick. Yeah, so you can measure readiness for school at 5 and see improvements in that over a 5 to 10 year period. So I think the early childhood ones you can measure at the population level and get a relatively quick growth. But with the childhood obesity one, we need to be cognizant of the fact that most of the drivers of that are the healthy food environment, the physical activity environment. They're not healthcare related, so we need to be careful that we're looking at things that we have direct influence over. So I think with the population outcomes, we just need to be like which of the ones that we are doing something that has direct impact very quickly, opposed to the ones that would be more appropriate in the PSP space, serviceable space.
Yeah, I won't repeat some of what I was going to say has been picked up, but just very quickly for me, there's 4 different outcomes: patient reported, population level, which Sarah's described, experience, which is slightly different to patient outcomes in a subtle way, and also clinical or technical outcomes. And it's actually picked up in the digital update report that we're trying to identify from a PROM perspective how we can actually do that universally and systematically within the organisation, aligned to the value-based healthcare approach which we're advocating. Because I think unless we can actually do something systematically, you won't get a universal and comprehensive view of outcomes that matter to patients. As I say, there's a range of how you describe outcomes, but hopefully with Welsh Government's agenda driving that, in the foreseeable future, we'll have a tool and a mechanism to actually capture outcomes more universally. But I think identifying what those outcomes are will be variable. We've got different data sets, internationally validated, various others. We're actually developing local data sets and getting those validated through the value team. So it's a good question.
it's a bit of a wicket issue, I think, for us. But how we do that is certainly the opportunity to do elements of it in the shorter term, but longer term for that wider impact, I think will be predicated on getting a systematic solution in place.
Thank you. Shelley?
Can I just say, I think Nicola would be disappointed if I didn't have something to say, because the outcomes for him is something that I've raised quite. I'm really pleased to see this actually, and it is quite easy to read. There is obviously improvements to be made, but I think your question at the beginning of the other group, you have to have a mix of performance and the outcomes. I think it's about us developing, as Rob said, particularly things that are important for us in terms of outcomes. And it's the point that Teach made about the triangulation. So I think once we've got those patient experience and we can do that more systematically, then we have more confidence that we're actually looking at the main things. I think the difficulty is there is so much that we could be looking at. I think we need to be clear. And as you've said, you know, stroke, and I think as time goes on, we'll develop those areas. I think what was useful as well is we did have more detailed appendices in the other pack, so you can go and have a look, and obviously that we wouldn't be precluded from asking questions on that. So I think it's a really good step in the right direction.
Any further questions? Thank you, and thank you to the team. They worked really hard in trying to get it.
Well done.
Thank you. Well, planned care position, off you go again, Nicola. So I do this on behalf of Leanne. So yeah, so planned care is obviously a key priority for our INTP and also for our and we've set up quite a robust structure now around planned care. I don't know, we shared some of that at the last meeting. We've got Leanne as the exec lead, and also we've got a planned care programme board. So I've got a number of work streams with clear objectives within it. I think it was also helpful that obviously Welsh Government then published the formal programme for transforming and modernising planned care really a few months ago, and recently in May the Auditor General also published Tackling the Planned Care Backlog in Wales report, and identify some key themes we should all be testing ourselves against, really, to make sure we have got a grip on this. And we've done some of our work already, and we formally responded to that. And I think we'll give us a bit more detail to our future board sessions and our Finance Performance Committee. I think again, just re-emphasising, we've got about 113,000 people sitting on our waiting list. That's about 1 in every 5 people in our population who are sitting on a waiting list. Around 77,000 of those are at the outpatient stage, and we've got about 25,000 waiting for a day case for inpatient. The Minister has been really clear about 2 particular targets that she wants health boards to deliver. One is eliminating that people waiting longer than 2 years for treatment, and she wants nobody waiting longer than 1 year for their first outpatient target at the end of December this year, and obviously being able to maintain that. So whilst I think there's a recognition across all of our programmes, there are 2 particular targets which I'll come to in a second. You know, relatively compared to other parts of Wales, we are doing better in this area than most. That doesn't make it good, it doesn't make it okay, but I think our system of having that separation of elective care at Gwent and Neville Hall has given us a bit more protection, and I think also demonstrates the work of the team around some of our outpatient work. But we really are focused on trying to make some inroads in this. And I think the biggest challenge is, you know, the guidance is still we should prioritise on clinical urgency. That is what we should be doing. Cancers, when we see an increase in demand for cancers, it reduces our capacity to deal with the routine. But we're also conscious of what is happening to these patients who are waiting, and they suddenly will become urgent by us not addressing their problems. So we are really trying to take all perspectives into account. And obviously, when you get into the detailed specialties and subspecialties, that's where the real insight is. But we've broken our structure of the health board into outpatients, maximising our elective capacity, diagnostics, patient information and active waiting. How do we support people when they're waiting? And also the different pathways we're introducing. And there's a little bit of information in the paper, just as a headline around some of the work that we're doing against each of these. So the bit that we specifically wanted to cover off as well today was around what our latest position is on these 2 big ministerial targets. Important, and the message is very clear. There's a recent position shared at the end of June, where we had about we had about 9,000 people waiting over 52 weeks for their outpatient, and we were down to around 6,000 for the 104 weeks. We were probably on the one target, probably, I think it's the 104. Nobody was even close. No other health board were either twice or 3 times the size of our position, and 52 weeks probably similar. We'd already, in terms of, first of all, 52 weeks for a new outpatient. When we did our IMTP, we said there would be around 9,300 people at the end of December. There would still be waiting for an outpatient, and pretty similar by the end of March. We've done a huge amount of work, and if you look at how our cohort, so we already know these people who are going to become 52 weeks, they're either breaching now or they will breach by December, so the cohort is known. And if you look at how our cohort is reducing, and Welsh Government have picked this up, it looks like we'll get there and exceed it. It's only when you go down to a specialty level that you realise that it doesn't quite work out as simple as that. You know. And what the work we've done is showing that we think we'll get there in all of them, apart from urology, ophthalmology, ENT, and some subspecialties within orthopaedics. All the others look like they can get there. If you take the aggregate of the subspecialties or the specialties, that number looks like it could be around 17,000 by December, not 9,000. So we've done quite a bit of, but that is assuming that our activity pretty much is the same as what we're doing now. And we know that we've got opportunities now with some of the COVID rules released, that we believe that the ideas and the programmes of work that those specialties have got to play, that we can mitigate that risk back to 9,000. So we are proposing that we hold our position so that we've got that ambition and that push to address. And we know some of them, when we do the validation, we contact the patients. Some people have either gone and sought private treatment or their situation's changed and they no longer need the treatment. So we believe that by holding the 9,000, we will get challenged by Welsh Government because the cohort reduction doesn't suggest we should be there, but we've got the specialty analysis that shows why we think we won't get there. So, and again, we can look at whether we need to realign capacity, depending on what the constraints are for each specialty. So I just felt it was really important to share that detail because we have gone down, and I've challenged really hard about why we're not going to maintain that cohort reduction, and the specialty analysis answers the question for me. So, but I didn't feel it was appropriate to increase that to 17,000, which was showing no improvement in our activity that we can do. There is still a risk because of our urgent increase or our, you know, and we've got to put more of our capacity towards that than we will struggle. But we believe it's an ambitious yet realistic target at this point. So that's that one.
Is the board happy to endorse that approach for the over 52 weeks by December?
It's not going to meet the ministerial expectations at this point in time.
No,
but they want it to be zero, but we need
an honest.
I think it is assessment realistic and ambitious because we are assuming we can mitigate about 8,000 outpatients from a straight line projection indicates.
Are you happy to follow that approach?
Yeah, I mean, I think it's really important that we are, you know, real and have a reality check. And when you look at things like the demand and also staff illness, etc. I mean, we've just got to be able to say honestly where we are. I mean, there was lots recently in the media about private treatment, for example, people opting for that because of the delays. I think again there's got to be some sort of honesty in terms of sort of what the reality is going to be for people, rather than the government saying, well, it's going down to 9,000 when actually the reality is it can't. So I think we need to just give that message, and if all health boards are doing the same, the message is either we need more resources or more staffing or whatever it is, and we know there's a big recruitment of staff exercise as well that's needed. So I think I agree entirely. We need to be open and honest and give a real position statement.
Yeah, I mean, I'd be very supportive of that. I think it's probably quite important for us to understand whether we think that 9,000 is going to come down in the next, 3 months after Christmas or 6 months or whatever, because it is an ambitious target, or whether we think the number of new people we're going to be getting in is going to stay at a certain level. I mean, I'm guessing from what you've said is because we've put a bit of an influx, haven't we? Because of people who've been waiting. So hopefully that figure will come down over time. And that's probably quite a good message to go back to Welsh Government with, I think, in terms of we are actually taking this ambitious target, but our projection is it will take us this amount of time to clear it. So I think that's, for me, that's one thing. The other thing that I wondered as well is whether or not there are people on one pathway who would find themselves jumped to a different pathway, perhaps because their condition gets worse or I'm not quite certain. And how do we measure them? Do we put them on a new waiting list and then start them at the bottom, as it were? Or do they still come in our 52 or 104 weeks? And that's something I just don't know the answer to.
And we can answer that at a different point. But I think obviously if somebody becomes an urgent, or they could end up in hospital and they would no longer possibly need, depending if it's the dressing main problem, there'll be some people who there's rules around if people are not attending or they, but we are trying, quite supportive to take people off the list without making sure we understand the situation. And some people will opt for, alternative approaches. So for us is making sure we contacting those people while they're waiting and they get communicated with. That's absolutely, and I know the team are always looking at those who are waiting over 52 or 56 weeks now. I mean, I think we probably need to do more of that. So that we understand if they are still appropriate for treatment, whether we've got the latest clinical information, they know how to manage the situation in the meantime. So that bit is really important, and that's one of the key priority groups, which is around that active waiting and patient information.
No, it is really important, and we must give them enough time to be able to respond as well.
Yeah.
Did you want to add to that, James?
Yeah, I really just wanted to come back at a point that Pippa made. So I completely endorse the process. It is as it is, and we have a finite pool of staff, and we've already just spent some time discussing how they're working with a much larger bed base than we expected, and it's these same staff who are caring for people and outpatients. I'm not sure I'd be quite as phlegmatic as you about the hope that demand will reduce in the future, because, for instance, as an example, referrals with suspected colorectal cancer are 30% higher than they have ever been, even pre-COVID. It's completely unprecedented. We don't know why, but they are appropriate referrals because the conversion rate for the proportion of people who are found to have cancer has remained pretty stable. And we're about to make that worse because very appropriately we're introducing different thresholds for screening in the community. And what we haven't sort of covered in any of our discussions at the moment is sitting behind all of this are our key support functions, our laboratories, our radiology service and things like this because of the complexity of modern diagnostics. And they are critically challenged across the UK. I mean, in fact, in this health board, we're in a pretty good position compared with other parts of the country, but we're nowhere near where we need to be in terms of the size of our engine, if you like, to manage the demand that's coming our way. And there is also medically a proliferation of new treatments that are really transformational. They're very expensive, but we are now able to treat a lot of people who we wouldn't have been able to treat before, which is fantastic. But also, again, particularly in cancer, there are a lot of people, cancer in a lot of areas is becoming a long-term condition, and people are not dying from their cancer, they're surviving, which is a triumph medically, but we almost not thought through the implications of how we manage a growing cohort of people when they have cancer as a long-term condition. So I just wanted to introduce that note of optimistic despondency.
Thank you. I was just going to ask about obviously the categorisation for operations, and obviously a lot of them are still category 4. Are any of those now being taken off waiting lists and having operations, or are they still waiting?
Well, I think it'll depend on the specialty within which they're in, because we are, as you can see, we are reducing our, when I come on to it in a second, the 104-week ones for treatment. So there are people being treated, but I think it'll depend on that specialty and the capacity they've got on the basis of the size of the waiting list. So I think that's more of a concern for us on some specialties like orthopedics. How are we ever going to get to it?
No, exactly. Pre-COVID days, it was always when I'm coming up to that sort of target, and suddenly all the people who have been waiting nearly 50 weeks or whatever it was then, suddenly we had to get in and operate, because are there any penalties now? Because there used to be penalties.
Well, I think in all fairness, that's what the Minister is trying to do, and I kind of support that approach to a certain extent. Is absolutely we want you to focus on clinical prioritisation, but don't forget about these people who are sitting waiting because they are living in a lot of pain or whatever. So the fact that we've now got these two targets on 52 and 104 week, I think is the attempt to motivate me to ensure that we don't forget about them. And I'm not saying we were, but I think is increasing a prioritisation about time in amongst a challenging position that we face. So I think it's a subtle introduction of time.
Okay, so sort of slightly bringing that back.
Yeah, well, I would also say we don't need penalties within the system. I'm dismayed that we're having to talk about 52 and 104 weeks. This conversation ought to be about whether we're at 8 or 12 weeks. Yeah. So we're having the wrong conversation, if you like, but it's the right conversation in the context. But the clinicians feel this really strongly. It's just mortally embarrassing. You know, I do clinics. It's mortally embarrassing seeing someone who's waited with symptoms for a year before seeing me. It's that is the driver. We don't need any external drivers.
I suppose the other thing, have we noticed, sort of going, certainly with the introduction, well, with COVID, the surgeons, we suddenly realised there are some things we could do as day cases, and people have resisted doing it before. We can't possibly send them home the same day. Has there been that move? Because that's obviously a positive move on your bed capacity and things like that.
I do think there's quite a lot at the specialty level as part of that plan care programme, where by trying to increase elective capacity, any areas where we think we can do more as a day case, you know, particularly in Neville Hall, we've got the opportunity to expand our day case provision. In particular, we are trying to max those opportunities, and I know that is something that Leanne in particular to the teams is focusing on, because all of I think we're trying to be realistic, but there's a lot of ambition out there to increase capacity with the resources we've got by being more efficient, looking at alternative pathways. There's an example in the paper on orthopedics where they try to look at different ways of triage. So I think the teams are working hard around doing something a bit different and innovative to, you know, get the best out of the capacity we've got, get people off the list.
One of the positives, I think, that came out of making us think in different ways.
It is pushing the boundaries on.
Yeah, thanks.
Did you want to add to that, James?
Yeah, I mean, one of the excellent bits of work that Leanne and her team are doing is really looking at how patients are allocated to our new system, really as part of this continuous review of the clinical futures model, because obviously there's a certain cohort of procedures that can only be done in the Grange, and there's a lot of work going on sort of testing, you know, what needs to be done in the Grange and what can be done on our other sites. And that's a good bit of work that would be quite impactful, I think.
Jenny, and then Paul. Just a quick question. My question is more from the patient perspective, and obviously you discussed the fact that people kept in touch and, you know, they're reviewed a lot happier. That's fine. I wanted to know how assured can we be as a board that how robust is that system? Because I've had a couple of people saying to me that they haven't had any contact at all, and I've said you've got to chase them. People don't like chasing; they don't want to be a nuisance. So I did mention it to Leanne, and she did say that they had difficulties with staff changes in the back office, you know, where they make the appointments and they contact people. So that's my only concern about this is I think the process, I think everything we're doing is absolutely on the button, but it's that contact with the patient that's waiting. So I just wondered, you know, how much work's been done about just validating what we're doing.
I think you're right, and you know, you want to make sure every single patient, you know, and what's the metrics to give us the assurance that's been done. You know, there's currently 9,000 of those. We've got hold of 6,000, 3,000 we've still waiting to get in touch with, or we couldn't get hold of. I think there is need to have some feedback back up in terms of how's that going, so that we are confident that people have been contacted and we have to place them. And I think that focus on, and you know, how we keep our way down the waiting list, because you know, different people will be coming into that cohort every month, and we need to make sure we've contacted everybody.
It's a very difficult area, I understand that, but again, I think from our reputational perspective, it's important. It's a key, you know, in getting people on board, and also getting people to understand that what they can do, particularly some of these conditions, you know, about losing weight and exercising and that sort of thing. You know, that sort of conversation with people, if it's appropriate, I think is key to, you know, helping everybody, because we're all in this together. It's not just about us doing this. Patients have responsibilities as well.
Paul and then T.
And just to support what Shelley has said, I think it's about briefing all those involved in the system as well as the patients, so that the GPs are aware of exactly what the situation is, rather than this would be, because I think it is reputational. I think there needs to be a real reality check. You know, when the NHS was set up, as a free service, everybody thought, well, illness would reduce. The demand has increased exponentially, and we've had a pandemic, and suddenly Pandora's box has opened. And I think for politicians to think, well, suddenly we can put all this right within 52 weeks or interval, I'm quite sure we will see that unless you get additional staff, resources, and all sorts of things in there to be able to do all this work, I think there does need to be a reality check. And I'm very concerned. We have a duty of care over all our staff. And I think sometimes we have to say, look, this is what we can do. This is the demands. We've got a surge in demand. This is the capacity we've got. These are the issues we've got. And I think we need to say, you know, we are doing everything that we can possibly do to help and support patients within our area. But we can't, you know, it's unrealistic targets or demands. And if it gets to that stage, I think we need to be able to have those questions, which I'm sure our chair will be.
We've already done that. We have been very honest with Welsh Government about what can and cannot be achieved and what we're doing about interviewing people. We maintain contact with people, and that if they are asked to come in for a procedure or an intervention, they have sufficient time to be able to respond. Because there's nothing more frustrating than being given an appointment and it's 2 days ahead and you can't actually get there. That is not an honourable way to behave with anybody. So yes, no, that the Minister is well aware that we will do absolutely everything we can, and aware of what we are unable to do, but what we're doing about it.
I mean, the other thing is just to I think politicians may not like this, but actually just let people get on and do the job. You know, because suddenly you get another plan, another target, and you're just about to do everything. You think about nearly there. Oh, another report to be filled in for somebody else who's sitting in an office that doesn't really, well, I don't want to be too critical, but you know, let the professionals get on and do their job, and just to sort of give a time where there's some freedom to be able to do that, rather than suddenly coming in with some, you know, new thoughts and ideas or targets.
That message is also being conveyed by the officials.
By the next
Right target.
Moving quickly on.
And just on that subject of the time, you know, from what we're hearing from the CHC, that people can't necessarily respond, can they? And again, I'll bring in the experience of the community. People are increasingly having to work longer hours, take on second and third jobs. So we may well find that people are choosing very reluctantly to live with pain and you know, difficulty, rather than take that time out. So that will impact on the flow of our values.
Yeah, well, I think we've got to monitor it ever so carefully. Make sure that we're providing realistic timeframes given the circumstances.
So can I just start in terms of it's the same principle for the 104 week, although we are projecting that we will do better than what we said in the ILTP and the latest submission, with a forecast that we'll get down to 2,500. I've been reassured by the teams. I think I'm probably a little bit more nervous about this one, but I think, you know, it's a big improvement from what we said. Again, the key target was to get to, you know, nobody's waiting 104 weeks in most specialties, and we will, you know, 3 or 4 specialties that we think we struggle to do this. But, you know, the teams are still focused on trying to get that to 0, but recognising at this point we think there's a risk of around 2,500 by March. But we are on an improving trajectory on this one every month. So we just got to hope that we can maintain that with all of the risks around the uncertainty of urgent demand cancers and all that we've already talked about. So we don't get to 0, but we do get to 0 in most specialties, because this one's a little bit looser, and we are showing an improved trajectory from what we've submitted before. So all of the other caveats are the same. And then just at the end of the report, we tried to show a little brief summary against the Auditor General actions, just a bit of a test for ourselves in terms of, do we feel we're picking up these up, which we do, but we'll do a more, Rami and I have been working through how we cover off our response to the WO, but we contend to this point that we're kind of on for this one, with lots of plans to try to improve in the context in which we're working.
Thank you. Any questions from that? So thank you very much for that, and I know everybody's working exceptionally hard to try and achieve these targets in the face of increasing demands and complexities. Rob, the delegation of revenue budgets Q2.
Thanks, Anne. So the paper outlines the agreed governance approach to budget setting for 22-23. Presents an update on the allocations that we've had for funding, both confirmed and anticipated. And it presents a proposed Q2 budget delegation plan, which is in line with the board agreed approach for this year in terms of taking a quarterly review of budget setting due to the uncertainties faced during this year as part of COVID and other factors. So this paper takes that position as an update for Q2. The assumed income levels at the moment, following a monthly position assessment, is 1.65 billion, and that includes confirmed funding and, most notably, anticipated funding for COVID-19 and exceptional national cost pressures. So for COVID-19, there's approximately £30 million for national schemes, that's like testing and vaccinations, and approximately £46 million for local response in terms of the pressures we're seeing as a result of COVID. In terms of exceptional national cost pressures, that includes energy, employers' NI uplifts, and commissioned real living wage costs, that's £23 million. And those two together, £99 million of funding, which we're expecting and anticipating from Welsh Government. However, you will hopefully note that the Director General's correspondence as part of the MTP that they are not confirmed at the moment, and Welsh Government themselves need to assess how that can be managed in partnership with us. It's worth noting the IMTP plan, in order to achieve a balanced budget and break even for the year, assuming £26 million worth of savings would be achieved, and mitigation of costs of £19 million, and any new cost pressures to be managed as well. So it's worth recognising in the context of this paper that whilst we're delegating budgets, there are cost reductions assumed in the plan. So there's key risks around the operational cost pressures we're experiencing at the moment, savings delivery, and Welsh Government funding. So having said that, our anticipated income is being used to support the proposal that provides at this Q2 point a full year budget delegation of our anticipated and confirmed funding, which is based on monthly forecasts. Being aware of the risks around receiving that funding, which is a national level risk. But this delegation of a full year figure will allow budget holders to better manage their budgets and their delegated responsibilities in the round of our estimated full resources. So I wasn't intending to go through the details of the paper. Recommendations are broadly to agree the anticipation of funds, acknowledge the risks, and support the proposal, noting that there will be a quarterly ongoing review provided to the board and updates as relevant to the proposal. Thanks.
Thank you, Bob. Any questions? I think we've got to note the serious position that the degree of uncertainty that underpins the ask for the delegation, and that every effort must be taken to draw back the anticipated overspends, and that we need to monitor this very carefully. Richard, please, as Chair of Finance and Performance, because the last thing we want to do is compromise services because we're overspending. I think it's really important we don't do that. Shelley?
Just as one point, Robin, I just only picked it up, was funding from the Welsh Government. You do say here that divisions may need to be adjusted in future months. All that, so, and obviously the risk therefore lies with the budget holder. So they're aware of that is a potential issue.
Subject to the agreement today.
Yeah.
I mean, what I'd like to do is depending on where we land with additional allocations, it would be better if we could manage that, say, from reserves rather than revisiting delegated budgets. But ultimately, we hope we aren't holding a contingency, so that is the only place to manage the risk.
Thanks.
One thing I wanted to raise is I think it's excellent report, and thanks to you and your team for its completion, is the uncertainties bit, which we're talking about. Travel, petrol seems to be coming down slightly, but we've got the utilities, we've got cost of living, and whether or not how that is factored in as part of any discussion with Welsh Government with regards to the current position and what the impact of that might be. Has anyone done an impact assessment on that at all?
In terms of the key factors that we're experiencing on a national basis, there's an ongoing regular beta review of those costs, the exceptional national cost pressures. In terms of cost of living and the implications, more so, presuming from a workforce perspective, there is work ongoing with that. I'm not sure where we are at the moment from a national response to that, but I know there's a lot of director peer groups discussing that and the reform of the Welsh Government of our likely pressures. NHS and Fed are taking it, for example. So there is work going on. It's not aligned to our core national pressures in terms of identification of a funding source at this point in time, as far as service delivery goes.
Right, I think we're in an unprecedented situation with regard to suddenly people looking at cost of living increases and salary increases. I mean, I read a report, I think that it was the nursing. I think we're looking at potential strike action. You know, we're in unprecedented times with regards to all sorts of reasons. And I think, you know, we need to be clear about what we need to do to support the finances part of it in terms of, again, another reality check, because our staff will be saying to us, we need and deserve an increase because we can't cope with all these pressures. And unless that resource element comes from a separate pot from Welsh Government or the national government to the Welsh Government, then we wouldn't be in a position to either afford that unless we cut services. So it's just trying to make sure we are looking to get that higher level really in terms of the funding for all that. Any messages coming from Welsh Government on that?
Not directly, but I think what I'd reflect on from practical aspects that we've been able to do have increased the mileage rates for travel expenses, and obviously with agile working and progressing that'll ease the burden to a degree where it's appropriate. I think, and I defer to other colleagues, they may be more updates, but it's certainly been looked at and considered. I couldn't give you a firm update at this point in time.
Sarah?
And in terms of pay award, we did have some early indication on Friday what the pay award may look like for our staff. And we're still waiting for further confirmation on the funding element of that pay award. And we also haven't had a response as yet from trade union colleagues in terms of the pay award that has been shared with the health board. So that I'm sure will come in forthcoming weeks.
Well,
yeah, and just to add to that, our financial plan nationally for all the NHS doesn't assume cost of the wage award at this point in time, but we are assuming, as advised, that it would be fully funded.
Yeah, that's the point of it.
Having said that, NHS Wales at the moment is in a very challenging position in terms of its forecast for all and the deficits around Wales, but that's our standing assumption as advised by the Welsh Government.
Okay, thank you.
any further questions? So we are content with this report and this delegation. Thank you. Might we have a break for 10 minutes? Yes. Thank you very much for the first part of this meeting. Could we now go on to 3.5, the arts strategy, Peter, please.
Thank you, Chair. So I am really delighted to present to the board the final version of the arts strategy for the health board. It's a 5-year strategy. I'm asking the board today to approve this strategy application. If I explain just a little bit about what I'm presenting to you. This strategy document has been co-produced by the Health Board's Creative Forum, which is a new forum that I chair and brings together anybody who's interested really to be involved in this work. And we also have a really active arts development team, and the strategy outlines how this kind of arts in health practice can be embedded across the Health Board. Just a little bit of context and how we've got here. It's been an awful lot of work happening on a UK-wide basis and in particular in Wales. In response to a UK all-party group around this, back in 2017, the Welsh NHS Confederation and the Arts Council for Wales developed a memorandum of understanding by sharing best practice, research, evaluation and celebrating the difference that arts in health activities can make to health. The memorandum of understanding was supported with the creation of an Arts in Health Strategic Capacity Fund, which the Arts Council for Wales oversees. And we've been fortunate in the Health Board to be able to access those funds as well, and in particular allowing us to recruit an arts project officer who has been instrumental actually in helping us develop this strategy. This arts strategy very much builds on a really strong track record for the Health Board in terms of applying arts in our environment and as part of our delivery of healthcare. A notable example would be the Arts on Grange programme, which has been successfully delivered, and I'm sure that you're all aware of that programme. But if you look at the strategy, throughout the strategy, we've shared examples, really good examples of arts in health projects that have happened already. A lot of the work we do in the Health Board in this area, we do in collaboration with partners, in particular the Gwent Arts and Health group, we refer to as GARTH, and they're really important for us in not only working in partnership, but also identifying sources of funding as well. And we're very successful at identifying funding, particularly charitable funds for the work that we do. So the arts strategy proposes a broad and inclusive approach to applying creative practice within healthcare delivery. It encompasses working within the built environment and capital development, and by engaging with and involving patients, staff and the wider community in projects that provide creativity and contribute to high quality, meaningful artworks. Probably make the point actually at this point that say artworks, it is really multifaceted and diverse. It's not just about pictures on walls, it is about creative activities. So whether it's music, whether it's poetry, one particular example that we're working on at the moment is looking at singing for lung health and that kind of thing. So it is really diverse range of arts. As a model of best practice, Arts in Health is able to support a sense of well-being through contributing to positive environments and participatory opportunities, raising participant and patient voice. It works with internal and external partners and creates an evidence base of good practice within the Health Board. Support for arts in health and for the strategy by the Health Board will ensure that conditions for an increasingly strategic approach to arts in health within the Health Board can be created, and for arts in health to become truly embedded and to be a key consideration, particularly for things like new builds and refurbishments, and when considering opportunities when we're working with patients and staff and for community involvement. This more strategic approach to the arts in health will allow the Health Board to maximise the possibilities and benefits by this, from this diverse practice alongside the existing provision. Just want to kind of share with you some of the governance that we put in place around this, and I referred already to the Creative Forum that has developed this work, but will continue to oversee it. I chair that group and I work closely with colleagues in corporate planning who are part of the arts development team. We will commit to evaluate this work, and we will also produce an annual report in terms of the achievements from the strategy. So the strategy is there, it's attached. If the board approves, we will publish it on the internet, so it's public facing, and it will also be made bilingual as well, and we've got arrangements to do that as well. So yes, today seeking approval to publish and launch this strategy. Thank you, Chair.
Thank you very much, Peter, and thank you and your team of real enthusiasts for getting us to having a strategy in this respect. Are there any questions or comments? Paul?
Just to say, I think it's an excellent initiative. I think it's excellent. And I've read some of the comments from some of the staff about what patients have thought the impact on families. So I think this is a sort of a wonderful example of joining up with others in the community to improve, using creativity to help health and well-being. So I applaud it and wish it every success.
Tish?
Thank you. Likewise, I very much welcome this and having that strategic approach, and I really welcome having that diverse look at arts in and around and what it is that's going to support people and make them and so on. I'm really pleased that we're looking at this all the way through from pictures on walls at the GUH right out to the community, and that really matters to me and more partnerships approach. As chairing charitable funds, we were going to be restructuring how we do things, so very much look forward to working with you on that and how everything fits. And then, sorry, just back to the diverse set of activities. I'd be really interested in how the traditional arts, if you like, pictures, poetry, song, music, and so on, also then extends to other activities that might interface with physical activity. So dance, for example, I feel that in the community, young people really respond and come through to a kind of healthier way of life because they can relate to dance, street dance or whatever it is that matters to them. And then finally, just really welcome some thought being put into cultural sensitivities and what it is that because we can really reach parts of the community that we might not be able to in other ways through. Thank you.
Thank you, T. Really important points. Pippa.
Thank you. I mean, it's brilliant. It really is. I just wondered if there's any link to the important murals that are springing up everywhere, just whether or not, because it was the cultural piece that I was thinking about. And for example, some of the ones in Pill are really reflective of the community, and whether there's any way we can link the two together and actually connect into the communities in that way. So I guess I'm partly reflecting what you're saying, Teach, but yeah, I mean, it's quite, there's quite exciting things that are going on.
Just comment on that. It's absolutely, I think that community engagement and encouraging people to be part of and participate in it is absolutely what this is all about, really. And a good example of that was the Arts for the Grange programme, where we actively engage with the community as part of that programme of work. And I think you can kind of see that in the work, really. And there's some really good examples of not just the local community around Cumbrae, but the whole great community, really. It's definitely part of what we would do from this strategy, absolutely.
Thank you. If there are no further questions, are we happy to endorse? Oh, sorry.
It was just on the physical activity point here, the very welcome parts of this and the Grange side, because the art in the outside space, encouraging people to leave the building and go for a short walk, to have from a wellbeing point of view, to have a complete break, whether that be staff or relatives, and then the link with the community garden. So I think that linking space between the building, the outside grounds, to a community asset. We've got an example of the Grange, and when we saw this as an executive team, I just reflected on the fact I was very grateful for the team because they came and met with me early on, and I sort of, you'd have been proud of me, Tej. I kept, I was downloaded it all in terms of the vision for outside space, and they took it all on board, and it's just wonderful. Thank you.
It's lovely. So do we endorse this strategy?
Yeah.
And thank you very much to you and your team, Peter. It's really good.
Thank you, Chair. Thank you, colleagues.
Right, 3.6, the community therapy musculoskeletal pathway at last.
Thank you, Chair. Me again. Okay, so just wanted to bring a paper to the board as an update on the work for the MSK transformation programme, which I am the executive lead and chair. So we've talked already earlier on in the meeting about planned care recovery, and I think that was probably a really nice lead-in for me in presenting this paper, really. As you know, planned care recovery has been added as a priority programme for the IMTP, and a key component of that programme is the MSK Pathway Transformation Programme. Whilst it previously existed as an organisational priority, it has really taken on additional focus because of the focus on planned care and what we talked about earlier. The waiting times now for people for planned care following the pandemic. So we very much refreshed the programme and really grateful for the support and input from the Programme Management Office that's allowed us to do that, particularly over the last 6 months. We've re-established the MSK Transformation Programme Board, and that's been really important for us to really move things forward. So I am really pleased about that. The refreshed programme management approach was strengthen the whole pathway, and we've really established 4 key work streams that the MSK programme will focus on. One of them is the community therapy pathway, which I'm going to talk about in more detail in a second. But also there's other work streams, and notably work stream 2 is outpatients and work stream 3 elective surgery. There's also a 4th work stream, which is post-operative care. I will first just briefly talk about work stream 2 and 3, because we are talking here about a end-to-end pathway transformation, very much integrated. So I don't want you to think about it as separate, isolated components. They are very much all connected. And when you consider integration is very, very important. And it's important that we connect what happens in the community with what happens in secondary care. And that's where the integration comes. And all stakeholders across the pathway working together is really important. So in terms of work stream 2 and 3, we have established these work streams in response to the Getting It Right First Time review of elective orthopaedic services. We often refer to it as GIRFT. But also the National Clinical Strategy for Orthopaedic Services. So on the back of that, we've established an Orthopaedic Improvement Steering Group, which is led by the Director of Operations and is currently scoping the work that will sit within work streams 2 and 3, and will sit under the governance of the MSK Transformation Programme Board. A bit of information in the paper about the governance structure that we have, and you can see how that shapes up. But in future board meetings, we'll bring more detail and information about work stream 2 and 3. But today I want to really focus on work stream 1, which is the community therapy pathway. So in terms of work stream 1, this is it's an evidence-based piece of work. It very much aligns to the Health Board strategy, which is to move care closer to home, to promote early upstream interventions with an emphasis on prevention and self-care. I'm really confident that the proposed pathway does that. The service will enable person-centred care, which we also refer to as care aims. And what that is about is co-creating care and treatment plans with individuals to respond to what really matters to them. And it's very much based on a holistic assessment. And in this sense, provides us with more opportunities to dehospitalise our care and tailor it to individual needs. And probably would have been nice to incorporate a patient story here, but I often think about my mum, who, I've been having trouble with her knee, and her X-ray suggested she should probably have a knee replacement, but she was referred to, not in Gwent, but she was referred to a community MSK clinic who were able to give her exercise and advice from pain relief. And she's delighted not to be having an operation. You know, she's regained her mobility and getting on with her life, and that's what matters to her, and that's what matters to me. Conversation is all about really. Understanding what is important for the individual. An important thing that I must stress that's really important is that this community therapy MFA pathways service will build on the best parts of the service that we have now. So I don't want to give the impression that this is a brand new service. We already have in our community an MSK therapy-led service. The issue with it is there are gaps in it. It doesn't meet the demand. The provision of it is not equitable across all parts of Gwent. So for some communities, it's hard to access. There are multiple points of entry, and we want to simplify that and make it easier to access. But I must stress, we already have a community MSK pathway, which is therapy-led. And our intention here is not to throw the baby out with the bathwater, but actually keep the best bits and build on that, which is kind of really important. So this pathway that we're proposing will simplify access to the service with a single point of entry, and it will ensure equity of provision for all Gwent residents. The pathway and service will offer a much wider menu of options for people with MSK problems. The expanded service will also support patients accessing urgent primary care and minor injury units for musculoskeletal pain and disorders, but not related to accident and injury. So just in terms of that wider menu of options for people in the community, I think this is really important in the context of our conversation earlier with planned care, and thinking about those people on those waiting lists, and you know, what are the options for them? Even if they do progress to surgery, what are the options for them while they wait, so they can increase their mobility, manage their pain, and just have a better life while they wait? Or what might be alternatives for them if they don't want surgery? And what this does, it really expands the menu of options for people in the community, far wider than we have now. It's important to note that some people experiencing MSK-related problems will still need more specialist interventions and help, whether it is specialist therapy in the community or whether it's referral onto secondary care specialties such as orthopaedics. This might be needed immediately, or it might be after having some of the community therapy intervention. I don't want to give the impression that you'll have the community therapy intervention and it'll just stop you going into secondary care. For some people, they naturally will. They naturally will progress into that. Every patient is different, and every patient will have a different experience. This community therapy MSK pathway protects the existing referral pathways into secondary care specialties. So we already have a well-established musculoskeletal eye service that we call, and that service refers into secondary care services, and that referral route is long-standing and well-established and agreed by secondary care colleagues. It is our intention to maintain that and not change that. Equally, this pathway work still allows GPs to refer directly into secondary care for patients that they see, and according to the criteria agreed at secondary care, they can still do that. So this arrangement will not change that either, and that's a really important point to note. What I want to do is focus on some risks and issues that have been identified as part of this development of the community therapy pathway. Back in December, when the executive team considered the proposal and agreed the investment from the Values Fund, at that point, secondary care colleagues did raise a number of issues and concerns, and it was important for us as an executive team to pause at that time and take stock of the issues and concerns being raised. It coincided nicely with the re-establishment of the MSK Transformation Programme Board. It provided a platform, if you like, where we had representation from all stakeholders, not just secondary care stakeholders, but also primary care stakeholders and our community therapists. And the programme board, I was really keen that the membership consists of the clinical directors of those specialties. So we really created with the MSK programme board a shared clinical governance structure, really, where we could not just consider the practical operational risks, but also the clinical risks if there were any, and we had a means to do that. So having that forum established for the last 6 months has really provided a vital platform really to consider and work through some of these risks and issues. And it was important that we paused at that time to take stock of them. What we didn't want to do was create any unnecessary risk in the system, and certainly no unintended consequences as a result of this work. So the report that is attached does summarise some of these risks and issues that were identified and are associated with the implementation of the community therapy pathway. These, as I said, have been identified by the programme stakeholders and have been subject to considerable scrutiny by the programme board over the past 6 months. In advance of bringing this paper today, I was very mindful that some secondary care colleagues, particularly orthopaedics, remain concerned about the implementation of the pathway. And on that basis, I requested the Orthopaedic Directorate put in writing to me a description of any remaining concerns and issues, besides the ones that we've already identified through the programme. I also provided an opportunity for them to share alternative suggestions to the community pathway if they had them. And I am grateful to the Orthopaedic Director for writing to me and putting their issues and concerns in writing. So the information that I've received, like I say, it did partly reinforce the previous risks and issues that we'd already looked at in the programme board and which are detailed in the report. But in addition, there are some additional points as well that were included, and I really want to share those with the board because I want to demonstrate really to the Orthopaedic Directorate that we are listening to their issues and concerns and taking them seriously. And what I absolutely do not want any stakeholder anywhere in the health board is to feel railroaded really into us doing this. I want it to be understood that we do listen to issues. We are genuine in our commitment to work with all stakeholders to work through this. Again, I will repeat, I want to implement a community pathway that is safe and that is achievable and does not create any unintended consequences. So I'll just work through some of the concerns because it's important that we air these in the board really. So there is concern raised about the level of scrutiny of the community therapy pathway by the stakeholders. I am, as I said earlier, I am content that now we've re-established the programme board, we have good representation from all our stakeholders at clinical director level, and that really does provide that opportunity for scrutiny of the work we're doing, not just of the community pathway, but also it will scrutinise work stream 2 and 3 and 4 as well. So I'm content we have that framework for scrutiny, and we have spent a lot of time over the last 6 months scrutinising that work, and we will continue to do so. The programme board will continue and will continue to have that function. But I just wanted to note there was concern about the level of scrutiny applied. There was also concern raised about the lack of clarity on the parameters for success with the community therapy pathway. In response to that, I would just reflect that the investment benefits are well documented in the investment case that was considered by the executive team, but further to that, some work has been done on identifying key performance indicators, which are detailed in the report and which will be further developed because they are going to be important to workstream 1 as part of their implementation. We need to know whether we're on plan or off plan, and it's those key performance metrics that will give us that guide really. I am laying out an open invite to all our stakeholders to help us develop those key performance indicators. So if any colleagues feel we've missed anything, obviously we'd add those in, and I'm always open-minded to do that. And it's important for me to note my expectation of the implementation of Workstream 1 will be that it is overseen by an implementation subgroup that reports to the MSK Transformation Programme Board, where we can seek assurance that that is being followed and the KPIs are being measured and monitored. And I've asked for very tight improvement cycles. So very much a pilot year for the first 12 months, we're very tightly monitored improvement cycles. So we can really look at those KPIs and understand whether we're on plan or off plan. And that will allow us to take immediate action if we are off plan and rectify and get things, make sure things are safe, which is really important. So just moving on through the concerns raised. Another one is the view that the community therapy pathway model should have been changed as a result of the risks and issues that had been identified 6 months ago. I actually feel that the scrutiny has been applied in the last 6 months through the programme board, and there's been a lot of discussion, and I've always said that this is not, the model we'll take forward in the community is never fixed down in time. It's something that we must continue to evaluate, and we will always change and modify and reflect. I feel quite strongly now that the best way to do that is to move into implementation. You don't really get to find out about whether something will work or not until you start trying it in practice. And I think we will learn as we go along. I think it's inevitable we will learn. No service, particularly at this scale, when you're trying to implement it, will be free of risks or practical issues. But you flush them out by implementing them, and you measure them, and you put them right when they happen. And I feel that's the best way at the moment now to kind of work through the issues and risks. And I will always be open-minded about changing the model if we need to. It's not fixed in stone. There is concern raised about the highly specialised physiotherapists who work in the community therapy MSK service and the ones who work now in the community therapy service. One of the comments made by orthopaedics, and I'll quote, is they felt they did not have the relevant medical qualifications or experience in order to assess or refer more serious causes of MSK pain. I should just say that the Health Board already has highly specialised physiotherapists who I can confirm are qualified to work as autonomous practitioners in the community, assessing patients in MSK pain. I'm confident of that already. Many of these therapists will see patients who have self-referred and have not seen a GP, so they are the first person to see them. That happens now. I am not aware, I have not been made aware of any evidence about cases that have gone wrong or serious incidents. But I would say that it will be important for the programme board to look at that and look out for that. And I would say not just in terms of the community therapy pathway, but the whole integrated pathway into secondary care as well. We always need to be alert to misdiagnoses and things like that, as we always do. And we have processes for that. We have clinical audit, and that's how we would do that. And you know, our community therapy service is subject to that as much as any other part of our service. And we'll have to demonstrate that the service we provide is clinically safe. Again, I will repeat that we have the added advantage that our MSK Transformation Programme Board is made up as core members of the CDs of the specialty, and that essentially forms an additional multi-professional, multi-specialty clinical governance arrangement. Another concern to highlight to you, there is concern that the community MSK pathway does not have an agreed referral pathway into secondary care. Just to repeat what I said earlier, really, the pathway actually utilises the existing already agreed referral pathway that we use for our community MSKI services, and that's been established for a number of years now. There's no plan to change that. There is also a concern about pain management for those people who will be seen in the community therapy MSK service. I should explain that, as is the case now, therapists will be able to seek pain support for their patients either through community pharmacists, through GPs, or through secondary care pain services. So all the options that are available to therapists now in terms of supporting patients with pain will continue to exist, and we will continue to utilise that. I also would say, I think there's probably further work we could do in terms of pain management in the community. And as this service develops, I think that's probably an area of work we could look at more closely and develop further. But at the moment, we're very much kind of looking at responding to and managing pain for our patients in the way we do now. Another concern for me to highlight is about the extent of the baseline assessment that was used to make the case for the investment. As I said earlier, the executive team were satisfied with the work to undertake the programme that was undertaken by the programme's resource modelling group, and that kind of developed the investment case. And that looked very carefully at a baseline of activity and outcomes that we have now, and that's pre-pandemic activity. But it's important to say that in terms of evaluation, we've committed as part of the community MSK pathway to evaluate using PROMs and PREMs. And that will be an important part of our evaluation as we move forward, and we're committed to do that. And my expectation as well is that PROMs and PREMs are also applied to workstream 2 and 3 as part of our work in secondary care services as well. For me, that's kind of essential really in terms of what we monitor. So in terms of like an alternative approach, I did invite orthopaedic colleagues to suggest an alternative approach. They were really keen to make note of the existing consultant-led multidisciplinary triage service that they have as part of their orthopaedic service. And it's one that I recognise, and I know it is a really great service, and one that I absolutely would expect to have and see at the front end of a secondary care pathway. I very much commend that service. I think it's great. What I would say though is that is not an alternative to a community therapy upstream pathway. It's something we need as well as, not instead of. And I am very much supportive of that work in orthopaedics, and we'd love to see it strengthened as part of our programme work. As I kind of alluded to earlier, there was a concern that the pathway work in the community with therapy services is not being integrated. I make the point that we're working on an end-to-end pathway transformation with MSK, and we've done this work already in the community, but we will be doing further work in secondary care now as well. It becomes integrated under the umbrella of the MSK Transformation Programme Board. These are not isolated parts of the service, but we have to put them all together as one integrated end-to-end pathway. That's how the integration comes. And I'm a great believer that the integration comes by all parts of the health board and all stakeholders working together. That's where genuine integration comes, and a commitment to work together in an integrated way, overcome problems, overcome issues and concerns, and demonstrate that we can knit these services together and these pathways together and create that integration. And I believe that's where integration comes from. So that's my high-level summary of the concerns and issues raised by orthopaedics. As I said, there were other concerns and issues raised in their letter to me, but they're detailed in the report, rather summarised in the report, because we've already been working on them over the past 6 months. But I will be happy to put the letter from the CD of Orthopaedics on the record of the MSK Transformation Programme Board, so that's kind of logged and we have that record there as well. It is really important for me in leading this programme that there is absolute transparency, and I'm giving everybody a voice and everybody gets a chance to, raise their concerns and issues, because I do recognise this is difficult and as all changes, and we're working in a very difficult environment at the moment as well, and I'm very mindful of that. I'm really pleased that our stakeholders are all engaging with the programme as it is at the moment, and I just want to note that in terms of primary care, we've done quite a significant amount of work with primary care and run this community pathway through them, and I was really pleased at the last programme board that the primary care colleagues are really endorsing this work and are on board with it. So that's a really positive note really to have their support. I have, so my final point, and it does relate to the issues and risks, is I have, through the programme board, assured the programme stakeholders that all risks and issues, some of which that I've summarised in the report and some of which I've described now, all will be managed and monitored by the Workstream 1 implementation group. And I firmly believe that we have to get into implementation now to work through some of these issues and risks. And I would categorise them as implementation issues and risks. They need to be owned by the implementation group and worked through, managed and mitigated or eliminated if possible. And that will happen effectively if all stakeholders contribute to that Workforce 1 implementation group and be part of a supportive network really of making sure the implementation happens safely and smoothly. I very much request really the support of secondary care colleagues to guide community therapy colleagues to do this safely and all work together. Of course, you will have the programme board and that will continue, and the programme board provides that overarching clinical governance, but also will seek assurance from the implementation group about the delivery of the outputs and the outcomes according to the agreed plan, and that appropriate controls are in place to avoid any unintended consequences, but also so we can maximise the benefits that we've described. I just want to touch very briefly on the funding, because that may be a question mark in your head. I can just assure the board that the required investment of 1.8 million has been secured by the executive team using the value-based recovery funding, of which the Health Board received a share from Welsh Government. And that was a really good fit for this community therapy programme. Just to explain, the value-based recovery funding of 15 million across Wales is to support NHS recovery over the medium term, and it has a focus on delivery of high-value interventions that ensure improved outcomes for patients and support service sustainability and reduced waits for treatment. So very much kind of fits the bill really in terms of this particular programme of work. And just to note that the funding is recurring. So to be clear now what the ask is of the board, on behalf of the executive team, I seek the board's approval to proceed with full implementation of workstream 1 of the programme, which is the community therapy MSK pathway, as described in the report. However, I am also recommending that the board tasks the chief executive and the executive team to lead the work to resolve the issues and risks that have been identified by our secondary care specialties, with the understanding that this will obviously determine the pace of implementation. I'm also seeking authorisation from the board to progress workstream 2 and 3 at pace, which will provide the necessary and urgent orthopaedic improvement for our health board as presented in the Getting It Right First Time review of elective orthopaedic services and the National Clinical Strategy of Orthopaedic Services. Thank you, Chair.
Thank you for that very comprehensive report and overview, and in particular for so carefully taking us through the concerns that have been raised and the mitigation of those concerns, which is really important. We have been waiting some time for the commencement of a musculoskeletal pathway for our population, so I'm very pleased that we have got as far as this today. Are there any questions, Pippa?
Yes, first of all, I really welcome this, and I think for people in the community, you know, there's a real opportunity here, isn't there, for people to be able to feel that they're in control, and then they're not just being put onto a waiting list somewhere or having to try and make an appointment with their GP, or, you know, all of the challenges that face people. There is a feeling of, if you can pick up the phone and speak to somebody who understands what you're going through and then says, why don't we try sending you here? And so I think from a population or a patient perspective, I think that's really great. And my question really is around how do we communicate the fact that we are going to have this pathway to people, because not everybody is going to go, oh, I think I'm just going to go look at the website and see if I can find out what's going on. And I know that the community physio service, you know, there was like leaflets in the pharmacy and what have you. I just wondered if you had any kind of plans for how we're going to make people aware of it. But yes, I'm fully supportive. So.
Yeah, thank you for the support. Yeah, making our community aware is really, really important. We've mentioned the website which we've developed. It's a really nice website. It's got a lot of kind of resources you can use immediately without having to contact anyone, lots of useful information, but there's also some good signposting of where you can get help from other sources, but also it will explain to you how you can self-refer into this community therapy service. And the self-referral aspect is really important. We want to make it as easy as possible. If possible, remove the step of having to go to your GP first, which is kind of a far better patient experience, I believe. But interestingly, we've learned a lot from our long COVID programme in terms of how to make the public aware of the service that we've created. And part of that was really carefully monitoring where the referrals are coming from and looking at different parts of the community across Gwent. And where we spot an area that's got lower referrals, we can start to target that with some additional information, not just to primary care, but other community partners to get the information out there. So that's part of our plan in terms of actively promoting the new pathway and how to use it, how to access it, that kind of thing. People will still contact via their GP, and they might need to see a GP or they might see a practice nurse. They might just talk to the receptionist. So it's really important that all our primary care partners are aware of this pathway and how to use it. Again, similar to long COVID and the work we did there, really, in terms of advertising that, really. And getting the word out there. You know, to go back to that self-referral, really important. You know, we have a lot of people on our waiting list at the moment. I genuinely believe some of those people will choose themselves to also use some of these services for them whilst they wait, and that would be great. You know, if by doing this we're giving people extra help in the community. I know there's a bit of concern being raised about demand, but you know, when you create a service that's great like this, they will come. You know, we will create this demand, and there's unmet demand out there. But I firmly believe that's our responsibility as a health board, where you know we want to make sure that there's nobody in Gwent who's suffering with MSK problems, who's not getting help. And I want to know about the people who we aren't reaching and we aren't getting to, because they're the ones I want to reach. That's our population responsibility, isn't it, really? And it will inevitably create demand, but we must rise to that challenge and deal with that, because that means people are getting the help they need.
Thank you. Any further comments or questions? Yes, Sarah.
I'd just like to draw attention to the addition in the performance measures, the measures around patients losing weight, because the evidence around losing weight helping is ever strengthening. And that point about demand and capacity, we have got capacity in the commercial weight management sector that we're commissioning, and that we've got spare capacity there. So that point about an active offer to people, for some people that will be enough to at least halt their disease progression for a while. And linking to our earlier conversation about outcomes, and measuring us on things that we can control in the proposed performance measures is patients losing weight through contact with our weight management services, and that's exactly what's in the wording of this performance indicator set. So using contact with us in order to support people to lose weight, this is one of those treatment pathways where losing weight is part of the treatment plan.
Yes.
So, and that's something we haven't been able to offer before.
Thank you. James.
Thank you very much, Peter, for that really sort of thorough review of the work that's been done up until now, and the very clear articulation of the clinicians' concerns. And I just wanted to reiterate, I think, what was very implicit in what you said, the importance of all professional groups continuing to participate actively in this programme to ensure that we end up with the best possible service for our patients. And also to reiterate my support that the clinical concerns raised by teams who've been involved, I think, can be addressed through the governance framework that you've already described in your presentation, and to give you the support of the corporate clinical governance team in developing that framework as things move forward.
Thank you, James. That's very reassuring. Thank you. Are we content then to proceed with tranche one?
I think Helen wanted to.
Oh, sorry, Helen.
No, I was just going to endorse and thank Peter for just your patience in getting it this far and actually seeking to address all their concerns. But I would, I suppose, encourage the orthopaedic surgeon to have a bit more understanding of what their colleagues do and the expertise that's out there, that's already in the community, so that you can all work together to develop a service which hopefully will have a positive impact for the work of the orthopaedic surgeons in the future. But I think, the way you've addressed all those concerns and helped to assure on the governance side is really important. And as you say, the next step probably should be to implement with very careful monitoring, which will actually hope to reassure them and also develop a very good service for the community.
Thank you very much, Helen. Are we happy to endorse the implementation of tranche one? And I think we should follow that up by an expectation that obviously this will be evaluated very thoroughly, but that we would like to see tranches 2 and 3 reported back here in 6 months, please. Yes. Even if it's an interim report, because this is the start of a pathway, and we have had the orthopaedic report now, and we have to see whether or not there is any scope for improving the pathway right the way through to rehabilitation of aftercare. Would that be all right?
Absolutely, Chair. Yes, of course.
Thank you. Thank you very much. Primary care sustainability. We have a declaration of interest. Chris.
Thank you, Chair. So we have 3 papers today in relation to primary care sustainability. This is in relation to a potential grant, and we're asking the board to consider a recommendation in relation to that paper. And the second 2 papers relate to GMS contract resignation and for the board for noting. So if we start with the first paper in relation to the potential branch closure, the Health Board received a request from the practice in April to close North Road branch surgery, which is in Croeso-Ceiliog, 4 miles away from the main site. The practice requested the closure of the branch in order to consolidate services on one site, describing it to maintain safe and sustainable GMS services in the long term. Practice identified and described a number of key challenges that they faced over recent years. Firstly, in relation to recruitment of GPs following the resignation of 2 GP partners over the last 2 years. The practice have had some success in developing the broader multidisciplinary team, and they've been able to recruit an advanced nurse practitioner, but they've been struggling to provide support to that MDT across the 2 sites. And the last area of concern highlighted by the practice relates to regular reliance on locum GPs. Many of them said they would not wish to work alone on a branch practice. Practice believe that from operating from one site, that would help attract new GPs to the partnership and provide a more sustainable model moving forward. So in line with the process that we have within the board to consider the request from the surgery, the primary care team implemented the process for considering branch closures, which included undertaking a patient engagement exercise and the establishment of the branch surgery closure panel. In relation to the patient engagement exercise and the main concerns identified there, people will see that in the attachment in the paper. Some of the key issues identified by patients. First area was in relation to a lack of concerns people had in terms of accessing the main site. So people talked about lack of transport, public transport difficulties and mobility issues. There were also concerns raised through the patient engagement exercise around a potential negative impact on the main surgery. People were particularly concerned around will there be additional numbers of people attending for appointments at the main branch and also access to the main site via telephones that people would be able to get through to the phone line. And the third area people highlighted in terms of another key theme from patients was a potential increase in travel costs for people to access and attend the main site. So those seem to be the main concerns that were being identified through the patient engagement exercise. So the branch surgery closure panel met at the beginning of July and included representation from the primary care division, the Torvine NCN, LMC and the Community Health Council. The panel considered the case provided by the practice and explored a number of issues, including those raised through the patient engagement exercise. And those are that discussion is sort of outlined within the paper that the board have today. Weighing up all of the issues, the conclusion and the recommendation from that branch surgery closure panel was to recommend the support to close the branch. That recommendation was subsequently presented to both the CHC Executive Committee and also the Health Board Executive Team, and both of those have supported that recommendation. So really the recommendation for the board today is to consider whether they are able to support the closure of the branch surgery.
Thank you, Chris. Questions or comments?
Have a process, so I think the CHC being involved, I think I would support the decision.
Are we happy to recommend the adoption of the recommendation that we have and approve it? Okay, thank you.
So, Chair, in relation to the next 2
Yes.
papers, I'm mindful of time and also that these are for noting.
Yes.
So shall I very briefly summarise them?
Thank you.
Okay. So both papers are related to resignations in relation to GMS contracts. So the first paper relates to Llanelli surgery, which is a list size of just over 7,000 people. And we were advised in March by the partners of their intention to resign the contract. The process that was implemented for this paper, for this surgery and for the second paper, was the vacant practice process. And for Glyn Every surgery, the initial preference was to try and fill the vacancy via advertising, both locally and nationally, and also exploring with neighbourhood practices if they were willing to come forward and volunteer to accept additional patients. So those are the three original options that people were explored. Unfortunately, the Health Board didn't receive any applications, and so the vacant panel practice reconvened at the beginning of June. Consideration at that point in time was then given to the other options, and the recommendation for the panel at that point was to disperse the patients through the practice list to neighbouring practices, but to try and work very carefully with those neighbouring practices, exploring what support they would require in order to support those additional patients. So the executive team supported that recommendation, and I'm pleased to report that work has been ongoing with those neighbouring practices to try and manage that dispersal and identify the support that those practices will require. So that's the thing in relation to Glyn Every surgery.
If you can keep us updated on that, it'd be helpful.
Okay, thank you. Shall I move on to St. Bride's?
Thank you.
Okay, so in relation to St. Bride's Medical Centre, in March of this year, we were advised by Dr. Collins of her intention to resign the GMS contract. So since January of 2020, she's been the single-handed contract holder of that surgery. Again, as with the previous paper, the vacant practice process was implemented, and it was advertised both locally and nationally. The Health Board did receive 6 business cases in relation to St. Bride's, and 4 of those progressed to an interview stage. Through the interviews, it was recommended from the panel that 3 practices would be allocated patients. First practice with the greatest number of individuals, it was St. David's Centre, and they would be awarded a contract to deliver just over 4,000 people. And as part of the St. David's offer, they would be retaining the existing St. Bride's Medical Centre. The other 2 practices who would be taking patients would be Bellevue Medical Practice, who would be taking slightly less than 2,000 individuals, and Malthus Brooks Health Centre would be allocated just over 660. That recommendation was supported by the executive team, and patient stakeholders and the CHC have been informed.
Okay, any questions or comments?
I just have one question, and I'll declare that I'm a patient at St. David's. And I think the challenge sometimes with some of these, and I guess it's just a point for noting, is that for patients, transport is always an issue. When you have Bellevue, for example, directly opposite St. David's, that is a challenge. So I'm very pleased to see that the intention is to keep the St. Bride's Medical Centre. But how do we follow up to make sure that actually they are putting doctors into St. Bride's rather than just keeping the premises open, but bringing the patients into what's already a congested area? So I just wondered if there was any sort of follow-up to that.
I will check.
Okay.
Okay. So subject to the checking, are we happy to note this report and recommendation? Tish?
Yeah, I am happy to do. There's a general comment. We know that with this immense pressure in the system, I'm absolutely assured of the process and being part of that. So that's great. My question is, so with all of these 3 that relate to us, the practices said to us, we need to. Are we getting upstream of that conversation as a health board and talking with our practices? Do we have a sense of where we might have other practices that might be in that place in 6 months and a year? And also, are we talking, and you talked us through the process by which we are advertising the opportunity there. Are we talking to other practices and empowering them and enabling them to put in place their kind of infrastructure and their confidence to possibly put themselves forward if other neighbouring practices are struggling? So it's kind of getting upstream of that conversation, because we know that's happening. We know that our GPs are retiring or wanting to move or close their practice or withdraw for all sorts of reasons.
I totally agree with you, Teague, and it is about, isn't it, what are our opportunities to be much more proactive and engaging in trying to identify practices that may be at risk. So there's a number of actions that we're taking in order to try and address that. So we've re-established our Primary Care Sustainability Board, and that's having its first meeting in August. And I think for me, I want that board to have two parts to it. I want the first part of that board to be very much around that conversation around strategically, creatively, what can we do to make sure our primary care services are thriving in 3 years' time, 5 years' time, 10 years' time, so being much more proactive. And then the second part of that board, I think, will be around some of the operational challenges that we're currently facing. One of the other things that we're intending to do through a series of workshops through September, and we've already agreed this with the NCN leads, is to hold a workshop with each NCN, which is very much an opportunity to have a conversation with them around what are the challenges for you as an NCN in delivering primary care services, an opportunity to share with them the workforce data for their NCN, getting them to think about that data, getting them to think about what that means for them, and then moving on to starting to think with them around, is there an opportunity and what will be required to encourage those NCNs to think about a business continuity for primary care. That's our hope. Whether we will be able to achieve that.
Thank you. I think we should have a board briefing on this in about 9 months when you've been able to do that preliminary work. Fine. Thank you. Okay. Complex and long-term care home and domiciliary care proposed provider fee uplift. This is a chair's action. Are you happy to endorse my action? Don't say no. Thank you. Ratifying the decision. On to 4.1, winter plan evaluation.
Okay, I'll keep it quite brief because obviously all the paperwork here. We obviously put together an overarching winter plan before winter, where we tried to encompass all the key aspects that were part of that, which included kind of trying to do the protection of our staff and communities, keeping people well, maintaining safe and healthcare services, supporting the workforce and keeping staff and communities informed. It was very much our winter plan, but underpinned by the winter plan of the Regional Partnership Board as well. So this report aims to try to capture what we think we did against the winter plan, what our predictions correct, what worked well, what didn't work so well. So just in terms of the front, I think what worked really well was the booster and the vaccination programme. We got hit with a new variant and we delivered a booster programme like no other, I think. It was 2 weeks prior to Christmas where we set a huge challenge and the whole workforce yet again stepped up and flexibly worked to make sure we delivered that, which really helped, I think, what could have presented as a risk for us in January. Our bed modelled, the bed modelling we did shows that, you know, what we talked about earlier, we were under significant pressure around our bed demand and particularly you know, some of that, those social care. But I think in terms of what we did do, we did identify that surge capacity, we did put it in place and that absolutely helped us. Many of our temporary staffing solutions helped us as we planned as well. And I think our winter comms engagement plan was very effective. And I think some of the work we did getting out into the communities when we could was very effective as well. I think what we kind of put down on the summary page was show promise. We had a number of ambulatory service models we felt very effective and we continue to evaluate those as to whether we should mainstream them. Some of our admission avoidance, again, we've seen some of those in the Q1 report to start to show some fruition. And some of our emergency care, urgent primary care, we think first. And the step close to home pathway we also modelled, did a pilot and we've been evaluating that in terms of how we move forward. I think the things that didn't go so well, we did get hit with an Omicron variant that we just, when we were doing the winter plan, I absolutely didn't. We knew a bit of risk, but it came quicker and faster than I think we thought it would. That obviously we saw a sustained increase in emergency medical admissions, we saw longer length of stays, we've seen reduced discharges, and I think the wider system pressure was probably even greater than we anticipated around the workforce challenges in social care. So flow through the system was particularly challenged. So I think what we've done is in the report try to draw out the things that work well, the things that show the promise, the things that didn't work so well, and we'll be using that to
develop our current plans and our plans for winter 22-23. So without spending too much more time, because I'm conscious of time, they were the probably key headlines I wanted to draw out. Sarah?
I'm afraid it's the moment I'd probably have to say to the board that there's a very high probability of a significant flu season that's coming winter. So therefore, learning from last year and potential for another COVID wave or whatever the latest mutation is at the time, and the two potentially coming together. So I just think we need to almost plan for it's a sort of plan for the worst, hope for the best, probably this winter. Because when I say that based on the actual data from Australia, where after not having flu this year, they have had flu. I know we thought we might have last year, but I think the sense and the epidemiologists think that it really will happen this year. And then because of the lack of exposure, the population's immunity is likely to be reduced.
So we must all get our flu jab.
Indeed, I was about to, we are going to have to really try and replicate the success of the COVID vaccination programme last year and achieve the same levels for COVID and flu this year.
Thank you, Sarah. That's really helpful. Are there any comments on the winter plan, Tish?
Sorry, can I just ask a question on the flu thing? So
Yeah.
So are there any plans to widen accessibility to flu vaccinations in a similar way as COVID vaccinations were available? So some people get their flu vaccinations free, public now, but not everybody does.
So the purpose of vaccination being to prevent serious illness, the UK group is the over 65s and clinically at risk, where the Welsh Government took the decision to extend it to the 50 and over group previously, and that has now been confirmed again for this year. So it has been lowered to 50 and over. So, and it does include, it was the last season it was extended to all school age children. So it's preschoolers plus all school age children up to the age of 16 and everybody over the age of 50 plus the clinically at risk in the middle. So it's an awful lot of the population.
Thank you.
Thank you.
Are there any further questions, Jenny? Can I just say on the winter plan, I think it's excellent in the way it's been set out, and it's clear about what I like is, is that this is what we said we do, this is what we've done, this is where we've succeeded, and this is where we need to do more work. So I think it's a really good model in terms of clarity of where we are. I just want to make that clear. So,
yeah, well, back to the team. In terms of the lessons learned for the future, I think we should all bear in mind the section under preparing for winter, and particularly in respect of the work that the RPB has to undertake in terms of the collective responsibility for implementing winter plans, because it's really important that we know actually what worked really well, what was successful, and when we talk about a step closer to home pathways, discharge to assess, exactly what are we talking about, exactly what are the components, which bits need boosting, what can we do better collectively, and to get a very thorough, clear evaluation of, yeah, this has done exactly what we wanted, or it's done better than we expected, or oops, this isn't working very well, and why isn't it, out of our control properly. But certainly I think for the benefit of both ourselves and the RPB, we need absolute clarity. And bearing in mind the scale that we're going to have to accommodate this next year, going into 23, I think we need to be very clear about what works and what we can learn. Paul?
Thinking about what Sarah said with regard to the children and flu vaccinations, that's something that the schools and the councillors will need to be aware of, our councils, and perhaps the breakdown of who's going to be doing what and what's required, which is helpful and in terms of what partner agencies can do to support the model or what's proposed, because then you could hope, hoping to account, you can say that, you know, schools will need to do this, or that the domiciliary care, whatever it is.
Thank you, but thank you for the clarity of this report, it's most helpful. Okay. The digital strategy update, you're doing a lot today, aren't you?
You impressed my preparedness. Yes, it's important to bring an update on where we've got to with the strategy, which we approved in July 2019. I'll just pull out some of the headlines. Obviously, our approach to digital had to very much respond to the pandemic, and as part of the strategy, we've accelerated beyond probably our ambitions at the time, and there's other parts that have had to kind of take a slower pace while we prioritised our resources. But the team have done significant amounts of work in the last 2 years. But just onto the key themes, you know, we have 4 very clear kind of pillars: digital community, digital organisation, data information, and the foundations. So just under digital community, and some of these we picked up, I think the big achievements in particular was around getting online COVID vaccinations booking, and you know that wasn't in our strategy in the beginning, but you know absolutely supporting patients and booking appointments. We've commenced a project now around prostate self-management platform, which is in development, but hopefully will enable people to self-monitor, and they are the type of things we would want to bring into an app in the future, but also should help our planned care agenda. And as we talked about earlier, that digital services for patients and the population is a key project that comes under this heading that we absolutely need to be involved in. And I think that's the real opportunity for in the future, that particular project. Those 2 are key priorities for us now going into the new year. Under the digital organisation heading, I'll just pick up 1 or 2. So I think WCCIS, we've talked, some of us have been here since the decision of this one. We are due to go live the middle of August, or 8th of August, the date is. As we speak today, we are confident that there's nothing to suggest there's a showstopper to stop us.
Which August?
This August. The team are meeting twice a week, and we've got a meeting on the 4th of August next week as a final kind of go no go decision. There are a couple of issues to pick out. We are not having the full integration that we wanted at the point of go live in the mobile app, which is a key, you know, is a key kind of asset to the system, are not going to be ready. But we are working with DHCW to hopefully have that implemented within the next 6 months. So we're trying to put them down with some clear dates and some clear timelines on that one, because there are a lot of benefits from those 2. But our view is there's a lot of benefit of going live without them, because it at least gives us what we've got now plus more. Just doesn't give us the full benefits of what those additional products will give us. So fingers crossed, all of it. We will probably be the only health board that has gone live with any significant volume of users. The other one I just draw, electronic prescribing is a huge priority now nationally. It's got some new momentum, and funding has been prioritised from the national funding. And this picks up what Dad was mentioning earlier about you've got to try and get the electronic prescribing in hospital in order to then get some of those linkages across as well. So a huge piece of work around electronic prescribing, and again, we'll be worth a session on at some point in terms of where we are with this particular, but huge opportunities both, I think, clinically and financially, if we can get this up and running. And there's a couple of systems, critical care, new critical care system due in January, and a maternity system replacement are 2 big specific services where we are due to implement those this financial year. And then the other one, which is we're up and running with it, but we've got opportunities for robotic processing automation. We did this as a pilot. There's been some really positive evaluation. We've secured ongoing use of 11 robots doing what we're already doing, but there is huge potential for us to use this more. So we're trying to put a bit of a formal programme structure around this, so that we're really clear from users what the benefit could be before we commit any more resources. But it is indicating a real positive project. Under digital data and information, I think our main issues around trying to get some more resilience around our data warehouse, and we've obviously invited
we've been using the signal for noise tool around predictive modelling and trying to improve some of our business intelligence in the organisation through that. And finally, around digital foundations, our big project in this now is around the development of a digital platform. This basically gives us the foundations with which we get much better integration of whatever systems come forward. That's my simple way of explaining it. I'm really excited for some of David's experience, but we could just test some of our thinking, but that is going to need additional resources around some of our software development, and we need to put a case together around that. I think I'm slightly concerned we are doing really good work within the resources we've got to try to maintain resilience around our computer rooms and servers, but capital is a huge constraint this year, and we are constantly assessing our position around that. We have quite a good set on cyber security and resilience, and that's a key priority now. We've made quite a lot of progress, but we've still got a lot of work to do. So lots of really good work, lots of priority programmes going into the new year. My big kind of concerns or priority to focus is around the digital platform. I think how we manage the resilience alongside restricted capital and cyber. Yeah. But there was some real positive projects around the digital programme, you know, the digital app for patients, e-prescribing, and some of those new systems for our services with robotics. It's probably a summarised version of where we're at. Thank you.
Are there any questions? Paul?
Just about really is very investing to save really in terms of really digital. I mean,
Yeah.
is that going to be is there a major problem on the funding? Is there any funding available from Welsh Government on this?
And when it
Otherwise,
was,
we're going to help that, can't we?
well, in terms of there was the digital investment fund, that's been cut to a certain extent because of some of the national constraints, although there is still money there, but they've been prioritised around the big projects, like some of the ones I've mentioned. But in terms of capital, there's just not enough capital to do what we need to do. And I think internally we've got to have a really robust business case and benefits case in order to drive some of these projects given our financial challenge. But I think resources is a key constraint which is out of sync with our ambition around this agenda.
Yes, that's right. Yeah.
And we're going to have to be really realistic about our prioritisation.
Yes. Yeah. Okay.
Yeah, David.
First of all, thanks to Nicola for answering and the team for answering a whole bunch of questions that I've been throwing at them on various parts of this. And I'm sure we'll be having more conversations as well. I think there's a lot going on, and I think it'd be really helpful to see some of those other bits back here, some of those programmes back here, and in various other forums over the next little while as well. There's a lot going on, and I think there's three big things that concern me, I guess, or worry me a bit. One of which is staffing, recruitment, retention, and retaining, building digital and technology specialists, and keeping that skill set is really difficult, and it's a national challenge. It's not anything that's just affecting us, it's affecting all the organisations, and we're not going to be able to solve that ourselves. So working nationally with other parts of health, with other parts of public sector, I think it's been really important so we're not stealing people from each other or competing against each other. So we need to do something there, I think. Funding, as just mentioned, is potentially a bit of an issue. Are we spending enough? Are we able to spend enough to be able to make the amount of changes we want to be able to make and make the transformation we want? But also the models around funding as well. So a lot of, particularly in technology and digital, things are moving more towards revenue and reoccurring spending rather than capital, particularly when we talk about buying in services and cloud services rather than spending on hardware. And so that needs to change in thinking about how we fund things. And we probably need to think about how we adapt our own funding models to support that. And then the third piece of that then is we're very reliant on national programmes for a good portion of what we want to do, whether that's WICIS, whether that's LINK, whether that's the e-prescriptions work. And where there are delays and problems with those, or we don't necessarily work, that isn't working as well as we'd like it to, that can have big knock-on impact to what we want to do. And that's a problem that we need to figure out how we manage. And the perfect example of that in this report is, again, the WICIS rollout in August. where yes, we'll be able to go live, we'll get some benefits. We're missing some substantial features that we were we were hoping we'd get from the mobile app and some of the integrations. And I think if we don't have those, that has a knock-on impact to what we want to do. There are other examples as well. We need to figure out how we can hold other organisations to account for not delivering what we need.
Exactly. Absolutely. Thank you, Bevan, for the support that you're giving our teams. It's much appreciated. James?
I apologise, Nick, I should probably know the answer to this question already, but the paper covers the need to update CWS because of its underlying kind of digital architecture. What isn't clear is whether the aim is to modernise CWS or whether we're looking to transition to another platform like Welsh Clinical Portal, because as the digital landscape develops in Wales, we will continue to have problems if we are running a different system from the rest of Wales. And I just wondered if you could provide some thoughts on that.
Yeah, so I know from conversations you and I have had, we do need to get a clearer strategy about that. It's picked up in the report kind of under the electronic health record outlining the source. The team's focus at the minute is about getting a digital platform robust, so that whether we use the platform or something else or something new we develop, then that's the foundation which we need. So I'm not getting past that conversation at the minute because that's what I've seen as the key priority. But I think through the digital delivery oversight board we've set up, I think we do need to have a clear direction of travel as to whether we think, and our conversations about the Welsh Clinical Portal is if we can offer a level of functionality that we can get currently benefit from our own system, then we need to migrate onto that. If not, I think, as we said, we can't carry on with a system that I know is probably out of date and needs to be.
Well, and coming to sort of monetary constraints articulated by Paul, and a very interesting conversation I had with David about how beneficial user involvement is when you're designing new systems. I have in my previous employment lived through 2 failed implementations of new electronic patient records, and my learning from that with the 3rd successful one is you need to invest a significant amount of time and money getting clinicians designing the front end right from the very beginning, or the system will fall over on day one, and there is a cost attached to that. The longer we leave it, the bigger the clinical risk is, I think.
And I think we probably do need to do a bit of user feedback, because there's a lot of clinicians who are absolutely wedded and love CWS. And yet the Welsh Clinical Portal is there as a national that gives us benefit as well. So I think there's probably a piece of work to start around, as part of that direction, whilst we get the platform in place to give us maximum flexibility for whichever direction we go in there.
We're sort of suffering from being an innovator. CWS for many years was probably a forerunner across the whole UK, but we suffer from the fact that it's an in-house developed piece of software, whereas there are huge commercial companies whose entire business is delivering electronic patient records.
I think the only query I put on, or concern I put on that, is quite often see in a lot of technology industries, but developing something in-house gives you the flexibility, gives you initially the flexibility you want, but can become a drag over time. But similarly, that happens with some of the big commercial providers as well, where they might develop something that works really well, but as that product gets bigger, as they add more and more features in, it becomes more and more difficult for them to innovate as well. And we see that a lot, particularly in some of the non-specialised industries like HR systems and finance systems, where pretty much every finance system and HR system that exists is fundamentally horrible and awful for staff using it. And the specialised industries, for example, healthcare and others, are worse in some cases. And so they have to strike that balance between something that recognising you might have to use something that isn't particularly good because they don't do that necessarily user research, and something that is custom built that might be perfect for staff but costs a huge amount of money, huge amounts of time, huge amounts of effort to build. And so we need to get the right balance there to deliver the right thing.
Well put. I'm very excited, David. So
Thank you. Thanks very much for that. The finance performance report.
Thanks, Anne. So this report presents the Health Board's financial performance for the period, the year-to-date ending June 2022. And the year-to-date revenue position reported as an £8.4 million deficit. Now that's £4 million worse than the original IMTP profile plan for the period to date, and £3 million worse than the revised plan we put in at month 2. So I'm sure I don't need to say that that's not a good position we find ourselves in. Overall, our income assumes funding as previously described for COVID-19 and exceptional costs, so that's anticipated to be received. Pay spend overall has decreased but remains above planned levels due to operational pressures driving variable pay. We have had the opportunity to release some of our provisions for annual leave, so that supported the position to a degree. Non-pay remains broadly stable in terms of expenditure for previous months, and savings, whilst in line with plan, it is a risk, a very significant risk around full year and full effect delivery. So in terms of the forecast, capital is due to be balanced, but that is stretched in terms of our allocation that we've received this year and subject to prioritisation of schemes. Revenue is at significant risk of achieving break even, and hence on the dashboard on the front page, whilst we put a 0 for a balanced position, we've now moved the rating to red. And that's largely recognising that we potentially have future months, 8-9 months available to us to see how we can manage those risks out. It's a reflection of that. And that's what has been reported to Welsh Government as well. A financial recovery turnaround approach has been instigated by the executive team to identify mitigating actions and try and develop options for consideration by the board. That'll be subject to the committee meeting later on. And improving the underlying position that we'd had aspirations of doing may be at risk depending on some of the actions we choose to take for this year as well. In terms of other key points, in workforce costs continue at levels currently beyond 21-22 average. There has been some positive movement, but we continue with significant reliance on variable pay solutions to deal with service plans and particular operational pressures, which are continuing. Off-contract nursing and enhanced care continues to be issues for us to deal with. In terms of non-pay, our continuing healthcare and discharge support costs remain above planned levels, and that's both from a volume and an activity-driven basis as well as price-driven, conscious of the fee paper we discussed earlier. In terms of other operational cost drivers that's driving the position, surge bed capacity, so we have consistently over 100 beds open, the surge bed capacity, delayed transfers driving some of that as well, averaging in excess of 300 daily beds, that is. Emergency and urgent care pressures continue, and elective treatment activity is being delivered close to planned levels, which is positive, but again is causing financial pressure for us. So just to repeat and review some of the anticipated income, COVID-19, overall we're assuming £76 million and exceptional costs, we're assuming £23 million will be received. Reserves, we have no contingency identified, and I won't go through the detail of that, I was subject to the budget delegation paper earlier. Savings, the savings plans identified in the IMTP, £26 million with £19 million cost mitigation expected. At month 3, we have £6 million forecast expected to be achieved. The profile of the year-to-date delivery of that is better than expected at 1.3 million. But it is the full year that's the challenge. In terms of the forecast, as I mentioned earlier, we've reported a balance, but it is RAG rated, reflective of the opportunity in terms of time for us to do something about that and take action, but without identifying further mitigating actions and reducing our costs at pace. Break even will be very difficult to continue to justify. and risks are identified in the paper and quantified. In terms of other targets for us, cash out balance was in line with best practice guidelines. Our public sector payment policy performance has marginally worsened. That needs improving, and there is a focused effort and a joint team approach to looking at how we can improve invoice payments and processing. As part of that, linked to some of our big commitments. So I was going to leave it there unless there's any specific questions. Conscious we've had an in-committee session.
Yes, we did. Are there any immediate questions, or should we pick those up in the incompetence side? Yep.
Yeah.
Okay, thank you. Thank you very much. The strategic risk report, please, Glenn.
Okay, again, I'll try and cover this quickly because I think we've covered a lot of these in the various agenda items, which is absolutely right to do. So really just to pick out some of the key highlights, you'll see that the number of strategic risks that we've identified has increased from 21 to 26. One of those that we talked about is an escalation of the achievement of financial balance, which Rob has reported on. You'll see that there are some changes within some of the risks as well. So de-escalation of a couple of risks around infection rates, and also implementation of WCCIS, which again I know Nicola referred to in her report. In terms of risks that have been that are being sort of managed, obviously the report highlights some of those, and again I think it's a reflection of probably where the wider system is in terms of pressure, demand for services, and our ability to respond with things like workforce recruitment and so on. So I wasn't really going to say a lot more than that, given the time that we've got. Thanks, Chair.
Thank you. Are there any questions on the risks? Obviously, when risks have been staying at the same rate for some time, we will expect an in-depth report about, are the mitigations right? Do we need to review these? Is the action actually helping or making things worse? So because these are very serious risks which have to be managed really effectively. So I must bear that in mind. The executive team report.
Again, thank you, Chair. Largely for information, hopefully gives the board a feel for the range of issues. And again, I think building on what other people have said earlier in the meeting, there are lots of things going on, lots of things that we're dealing with at an operational level. And what we're trying to do in the report is just capture some of the key things that we have to consider and manage as an executive team. There are also some service updates there, including things like the vascular network across South East Wales. So again, just drawing the board's attention to progress on that. Again, there's quite a lot in this report, so rather than go through it all now, given time, I won't. Finally, really just to sort of draw to people's attention, there's some of the staff recognition and awards and things, and obviously we were fortunate that one of our staff went along to receive on behalf of NHS Wales the George Cross for all the efforts during COVID. So I thought it was important to draw that one out, but there are obviously many other very noteworthy achievements and events that have taken place as well. So thank you very much, Chair.
Thank you. Are there any questions on the executive team report?
Really useful. Thank you.
Thank you. I cannot fail to notice that we have finally managed to get vascular services sorted out to be implemented. We will keep a very, very close eye on how well this is working, but I'm pleased that the cooperation between the three health boards has been effective in making this change and getting a vascular network in place. I think we were the last in the country, weren't we? Something like that. which is not to be recommended, but nevertheless it has happened. And I think also we have to note the success of our liver team in the excellent work that they have done, which has been recognised. And I've asked that at the next meeting we have a presentation from the liver team about what they're trying to achieve, how successful they were, what are their next steps, and hopefully we'll be able to arrange a short visit for independent members to go to that ward and see how they've achieved, and the huge enthusiasm there is on the ward, and the great patient satisfaction that is palpable as soon as you walk on. So that is really, really helpful. And also to reiterate our thanks to everybody who's received awards and the recognition that they have, which is very well deserved. So thank you for that. Your joint committee activity.
Thank you. So again, I'll do these quickly. I'm very grateful to Nicola and Rob who attended these during July for me while I was on leave. So I wasn't actually at the meetings myself. So you've got the brief updates here for both WISC, so Joint Committee of the Specialist Services Committee, and then obviously the EASC, which is the Emergency Ambulance Services. So as you can imagine, some pretty high priority issues coming up in both of those. I know that WISC were looking at planned care recovery for specialist services. I think today received some of the presentations. I've not had a chance to look through them myself in detail. And obviously in terms of emergency ambulance services, we know the ongoing pressures around urgent emergency care and the impact it's having on handover delays. So again, a main feature of the discussion and the actions taking place in EASC. So again, I wasn't going to say any more than that, partly because I wasn't in the meeting. But happy to take any questions.
Add anything to it? You too?
Most of in terms of WISC, most of the debate was around process in terms of existing plans. Some of the recovery actions reflected by some of the providers, I would suggest they're suffering with the same symptoms we're experiencing in terms of other operational pressures and the ability of the workforce and the teams to deliver what was actually commissioned.
Yes, it is a very serious concern to which we will return.
On EASC, Chair, like just so there's a clear action plan now being signed off, which will be the main focus of all the monitoring. There's a couple of key metrics which are monitored weekly for all health boards. The one thing that was being introduced this Monday was a stronger escalation of immediate release protocol. So this is if all the ambulances are caught up at the departments and there's a red call, which is an immediate life-threatening call, which are usually about 4% of calls. And for some reason, usually the ED department is asked to release an ambulance immediately. We usually keep a bay ready for a red release situation. But if there is a refusal for a red release, then that gets escalated to the executive much quicker than what the current protocol. So that was signed off by EASC, and we discussed that in the executive team last week, and it's been implemented this week. We generally pretty good on this health board for. We do have some exceptions, but it just will be it's a slightly quicker escalation, which I think is fine.
And what about the Amber 1 escalations? Was that discussed?
That wasn't discussed specifically. Okay. Other than the part of the regular monitoring is the average call, the average response times for Amber patients as well. Which I think is helpful.
Okay, thank you. Key matters from committees of the board. Patient safety, Pippa, anything you wish to highlight?
No, I think there's everything in the report.
Right. And we shall be having a report to the next meeting of the board on maternity services, which I think will be helpful. Audit, Shelley?
Anything to
Mental Health Act, Pippa? Yep. Finance and performance, Richard?
Because then to reiterate what I said before.
Okay. Nothing from partnership and shared services.
I don't think there was any.
No,
Sarah.
Nothing to highlight.
No.
Good, thank you. And that brings us to the end of our public board meeting. I apologise for it being so enormously long, but there was an awful lot of important work to get through, and I didn't wish to rush comments. So our next meeting will be on the 28th of September at 9:30, and thank you very much for attending.